very few people, but we are the most important people here. So I think we open the session and hope we have same successful day like yesterday. It was beautiful actually, and hope today as well. Maybe in half an hour everybody will be here. So Dr. Mawad is chairing the first session in the upper GI.
Before that, can I just take 1 minute?
Yeah, you can.
You know, in all honesty, it is so humbling to have Dr. Falah with us. And really, I mean, yesterday afternoon, it must have been around, I don't know, 5, 6 o'clock. And then he was still sitting there, sharp, very attentive. And really, it was a moment that I was so humbled. So it is a great pleasure to have Dr. Falah with us, really. He's an icon in this country, icon in oncology, and it is such a pleasure. And it gives me an immense pleasure to, although that this is really a very small thing, Dr. Falah, but this is a token of all the all your support and just being here, just being present. It is really a great honor to have you here. Thank you so much. Thank you.
Thank you very much, Saeed. Just in February, inshallah, I will be top in 40 years in UAE. 40.
Assalamu alaikum. Good morning, everyone. It's my absolute pleasure to moderate the first and the most, I think it's very amazing session, GI cancer, with definitely groundbreaking studies and changing landscape of treating upper GI. The first speaker, Dr. 𝗕𝗲𝗀𝗂𝗢 𝗂𝗂𝗀, Chief of Cancer Center, Chief of Quality Officer and Oncologist, Hematologist, American Hospital, Dubai, will talk today about overall survival and association of pathological outcome with event-free survival in Matterhorn.
Thank you for the introduction. Good morning, everyone, and thank you for the invitation. I was given the task to present updates on the Matterhorn trial, which in my opinion, and most our opinion, is really the practice-changing study. So this is basically an update of the final overall survival. We know that the interim analysis, there was a trend for overall survival, but this was presented at ESMO just recently about the final overall survival. And also in the same presentation, I will address the association between pathological outcomes with event-free survival, meaning is it better to have pathological complete responses or major pathological responses to get a better event-free survival. So the background, as I mentioned, it's a phase 3 study. We know from before that adding durvalumab immunotherapy to the FLOT regimen in resectable gastric cancer versus placebo with FLOT perioperatively resulted in improvement in event-free survival. And as I mentioned, the pathological complete responses, the major pathological responses were also improved by the addition of immunotherapy, and there was a trend towards the improvement in overall survival. So evidence also always in different trials suggests that if you're able to achieve a pathological response or nodal downstaging, then these are associated with improvement in survival with gastric cancer. Here, the report is about the final overall survival analysis in the intention to treat population and in different subgroups, actually. And also, as I'm going to show you, regardless of the pathological response, major, complete, then these people benefit in regards to event-free survival. So we're all familiar with the schema of the study. These are patients with stage 2, 4A gastric cancer, no evidence of metastases, who will be receiving neoadjuvant chemotherapy with FLOT. And they were randomized around 900 patients between FLOT, the typical 4 cycles of before surgery, then typical 4 cycles after surgery. Or the second arm included durvalumab added to the FLOT regimen, pre-operatively and post-operatively, 2 cycles pre-operatively, 2 cycles post-operatively, but continued on durvalumab for a total of 10 cycles. And the primary endpoint was event-free survival, secondary endpoints overall survival. So these are the statistical consideration. They tell you how they were able to analyze the final overall survival data. And that's a very important curve. You can see here that by the addition of durvalumab to the FLOT regimen, pre-operatively, post-operatively, and then 10 cycles of maintenance, resulted in statistically significant and clinically meaningful improvement in overall survival versus FLOT alone. And you can see here that the curves start to separate approximately at around 13 months, and they continue to diverge all the way. And this is a median follow-up of around 43 months. This is a median follow-up of 43 months. And you can see at 36 months, for example, the difference, the delta is around 6.7 absolute benefit in overall survival, 68% versus 61%. So this is the final analysis of with a hazard ratio of 0.78. Who benefited from the addition of durvalumab? These are most key subgroups. You can see here that all patients benefited. I will be discussing more in regards to PD-L1 status because this was a subgroup that was analyzed regardless of the primary tumor location, regardless of the clinical lymph node status before starting treatments. In regards to the PD-L1 status, we know that both groups benefited, PD-L1 less than 1% or PD-L1 more than 1%. So regardless of the PD-L1 status, there was improvement in overall survival by the addition of immune checkpoint inhibitor. And you can see that the hazard ratios are really similar, 0.79, 0.79. So both groups, regardless of the PD-L1, achieved an improvement in overall survival by the addition of durva. What about the pathological and nodal assessments? You can see here that any pathological response was achieved in 87% of patients. 16.5% had a complete pathological response. 25% had a major pathological response. What I mean by major, as you know, is between complete and partial. Less than 10% viable cells, and 25% were able to achieve even major pathological response. What about the nodal status? You can see here that at the time of the surgery, around 51% had no nodal involvement, while approximately 48% still had nodal involvement. Now, the question is it better if we achieve a pathological complete response in regards to event-free survival or major pathological response? Here you can see all the graphs and different achievements of pathological response. You can see that any pathological response resulted in event-free survival. Complete pathological response the same, major pathological response the same, but maybe the hazard ratio is a little bit different. It's 0.29 if they achieved complete pathological responses, 0.32 major pathological response, and 0.6 any pathological response. But regardless of the pathological response, you expect those patients to do better than without immunotherapy. What about the nodal staging assessment by investigator? Here you can see that 58% had node negative, 44 with the addition of durvalumab, 44% with the placebo. So really, they were also better downstaged, and really you can see node involvement. But what if the nodal involvement is positive or still have positive lymph nodes or negative lymph nodes? Also, this did not matter because both achieved an improvement in event-free survival, even if they have positive nodes at the time of the surgery. The hazard ratio is 0.77, the same as if they achieved node negative. So you can see here that the event-free survival was beneficial regardless of the node status at the time of the surgery. So in conclusion, addition of durvalumab to the FLOT demonstrated a statistically significant and clinically meaningful improvement in overall survival versus FLOT alone in the intention to treat population, hazard ratio of 0.78. Regardless of the PD-L1 status, that's very important, the same hazard ratio as I showed you, regardless of the pathological response, even if it's not complete or major, any pathological response, they were able to achieve a better event-free survival. And regardless also of the pathological nodal status, even if they still have positive lymph nodes, these patients were able to achieve a better event-free survival. And thank you so much for your attention.
So To the second presenter, Dr. 𝗕𝗲𝗀𝗀𝗀𝗀 𝗀𝗲𝗀𝗀𝗀𝗀𝗀, a consultant medical oncologist from Dubai Hospital, who will be speaking today about Skyscraper 07. It's a phase 3 study testing atezo plus tria in unresectable esophageal squamous cell carcinoma post-definitive concurrent chemoradiotherapy.
Thank you for the introduction. Assalamu alaikum. Good morning. So over the next 15 minutes, I will be just going through this study. This is a negative study, so I was not really sure why this was part of this, but we will go through this. So, okay, so Skyscraper 07, phase 3 randomized study of atezolizumab with or without tiragolumab in patients with unresectable esophageal squamous cell carcinoma that has not progressed following definitive concurrent chemoradiation. So a bit of background. So standard of care for unresectable locally advanced esophageal squamous cell carcinoma is definitive chemoradiation therapy followed by active surveillance. And we know that up to 60% of patients, they do experience recurrence after definitive concurrent chemoradiation, and 5-year survival is up to 30%. So all major attempts to improve survival has failed since definitive chemotherapy was established standard of care many years ago. So chemo-RT, in fact, it can change the composition of and lead to more active tumor microenvironment. And theoretically, it can enhance the efficacy of subsequent immune checkpoint inhibitors. So TIGIT is a novel co-inhibitory receptor and immune checkpoint. It's expressed on activated T cells, natural killer cells, and T-regulatory cells, and is implicated in several cancers, including esophageal cancer. And tiragolumab is a human anti-TIGIT monoclonal antibody. It may augment anti-tumor responses when combined with other immune checkpoint inhibitors. So the addition of tiragolumab plus atezolizumab has shown anti-tumor activity in advanced tumors, such as esophageal squamous cell carcinoma, including the Morpheus EC study in the advanced setting. So this is the design of the Skyscraper 07 study. So it's a global phase 3 randomized double-blind placebo-controlled study. Patients were recruited between 28th of September 2020 till August 2023 at 166 centers in 28 countries or regions. So key eligibility criteria, stage 2 to 4 squamous cell esophageal carcinoma, availability of tissue for PD-L1 testing. Patient received concurrent chemo-RT, a definite concurrent chemo-RT, and there should be no progressive disease after definitive CRT. Patients were then randomized to Tira 600 milligram IV 3 weekly, plus atezolizumab 1200 milligram IV 3 weekly, or the second arm was atezo plus placebo, and the third arm was placebo plus placebo. So the treatment was continued until disease progression, unacceptable toxicity, or up to 17 cycles of treatment. So if you look at the primary endpoint, primary endpoint were a dual immune checkpoint inhibitor, Tira plus atezo versus placebo. Investigator assessed progression-free survival and overall survival. And the second primary endpoint was atezo plus placebo versus placebo. And there were a few secondary endpoints in the study. So Skyscraper 07, it aimed to determine the efficacy and safety of atezo with or without Tira in patients with unresectable squamous cell carcinoma of esophagus post-CRT. So this is the statistical analysis and plan of this study. So this was a hierarchical testing. So meaning that first they will test the primary endpoint, which is investigator-assessed progression-free survival, and in Tira plus atezo versus placebo. If a statistical significance was reached, then they move on to the next primary endpoint, which was OS in Tira plus atezo. And if this was achieved, then they move on to another primary endpoint, which was Tira plus placebo versus placebo. So large study, 760 patients. In each arm, you see around 250 patients. So these are the baseline characteristics of the study. If you see, median age is around 66, very well balanced across 3 arms. Majority patients were above the age of 65, predominantly male patient population, and other disease and patient characteristics are very well balanced across 3 arms. So this is the results of the study. Primary endpoint was invasive investigator-assessed progression-free survival and overall survival with dual immune checkpoint inhibitor. So there is no difference in progression-free survival comparing with placebo, 20.8 months versus 16.6 months, with a hazard ratio of 0.0947 and the confidence interval crossing 1. Similarly, if you look at the overall survival with dual immune checkpoint inhibitor, there is no difference with a hazard ratio of 0.91 and confidence interval crossing up to 1.18. So if you look at the different subgroups of dual immune checkpoint inhibitor, there doesn't seem to be any group which has any benefit from this combination. This is the PFS and OS in atezo plus placebo versus placebo plus placebo. So on the right-hand side, you see the primary endpoint, which is overall survival. There does seem to be some benefit with hazard ratio of 0.69 with atezo plus atezo single agent atezo. On the left-hand side, you see the secondary endpoint with dual immune checkpoint inhibitor versus placebo. There does seem to be some benefit with a median of 29.1 months versus 16.6 months with a hazard ratio of 0.74. Again, PFS and OS according to subgroups in atezo plus placebo versus placebo plus placebo. So there does seem to be a benefit with the atezo plus placebo compared to placebo across various study subgroups. So this is a progression-free survival and overall survival in 𝗕𝗲 plus atezo versus atezo plus placebo. This was one of the secondary endpoints. On the left-hand side, a progression-free survival, there doesn't seem to be any difference with a hazard ratio of 1.13. Similarly, on the right-hand side, you see the overall survival with a hazard ratio of 1.36. If you look at the safety summary, obviously with the dual immune checkpoint inhibitor, you expect high toxicity. You see the treatment-related adverse events were higher, 75% in the combination versus 65% in the single agent atezo and 55% in the placebo arm. Similarly, if you look at the grade 3 adverse events, they are higher in the 𝗕𝗲 plus atezo arm. So these are the most common adverse events. So this is the conclusion of the study. Skyscraper-07 did not meet the primary progression-free survival endpoint for 𝗕𝗲 plus atezolizumab versus placebo in patients with unresectable locally advanced esophageal squamous cell carcinoma following definitive chemoradiotherapy. No overall survival benefit was observed for 𝗕𝗲 plus atezo versus placebo. Atezolizumab monotherapy demonstrated clinically meaningful improvement in progression-free survival and overall survival versus placebo, and the benefit was generally observed across key clinically relevant subgroups. So per the hierarchical testing plan, formal statistical testing comparing the atezolizumab plus placebo versus placebo arm was not done after the primary PFS endpoint was not met for 𝗕𝗲 plus atezo versus placebo. So tiragolumab plus atezolizumab and the atezolizumab plus placebo demonstrated a tolerable safety profile consistent with previous observation. So as demonstrated in Skyscraper-07, atezo following definitive chemoradiotherapy is the first and only treatment to show a clinically meaningful improvement in PFS and OS since definitive chemotherapy was established as the standard of care in this patient population. Thank you.
For the third presentation, I would like to invite my friend and colleague, Dr. 𝗘𝗦𝗠𝗢 𝗂𝗪, oncologist at the Dana Hospital BMC, will be speaking today about bemarituzumab plus chemotherapy for advanced gastric cancer harboring FGFR2b overexpressor, Fortitude-101. Please, Dr. Mazen.
Thank you, Dr. Modda, and thanks for the EOS. My presentation will be about the combination of bemarituzumab with chemotherapy for advanced and locally advanced unresectable gastric and gastroesophageal cancer and testic gastric gastroesophageal cancer. This is regarding the Fortitude-101 trial. So actually, FGFR2b is isoform of the fibroblast growth factor receptors. It is expressed in a number of cancers, including the gastric and gastroesophageal cancer. The combination of bemarituzumab with chemotherapy is investigated in FIGHT-2 trial, which is phase 2 trial, and this trial gives promising signals for the increased survival. And the fibroblast growth factor receptor actually is tyrosine kinase receptor that plays an important role in the proliferation and the disease progression while pertuzumab is first class of the monoclonal antibody that blocks these receptors and also induce the ADCC. So in Fortitude 101 trial, actually it is a global, double-blind, randomized phase 3 trial that investigate the people, the cancer patients that have local advanced unresectable gastric and gastroesophageal cancers that are HER2 negative, and with combination of BEMA with chemotherapy FOLFOX in comparison with a other group, which is combination of FOLFOX with the placebo. The patients should be overexpressed of at least 10% of the cancer cells with FGFR2b with the immunohistochemistry 2 plus or 3 plus. And these patients are randomized into two arms. The primary endpoint is overall survival in patients with FGFR2 expression at least 10%, 2 plus, 3 plus of tumor cells, while key secondary endpoints was the regression-free survival and overall response rate. The safety in all randomized patients also. A study had 90% power for overall survival, which required 214 deaths, assuming a true hazard ratio of 0.64. An interim analysis was pre-specified after approximately 70% of the 214 required death occurred. The primary endpoint was met at the interim analysis, which therefore became the primary analysis. All the statistical testing was conducted at the primary analysis, and subsequent efficacy analysis are description only. Patients in the FGFR2b of at least 10% population were enrolled between May 2022 and June 2024. 43% of patients were randomized in the last 6 months of the enrollment period. Now, this is the basic baseline characteristics showing the efficacy analysis set with FGFR2b overexpression of at least 10% of the tumor cells on the left side, while the safety analysis set on the right side. And the patient characteristics are balanced between these two sets. Regarding the overall survival results shown in this, this graph showing the separation of the two lines with the median follow-up of 11.8 months, it's found that the combination of BEMA with chemotherapy overall survival is 17.9 in comparison with a placebo chemotherapy is 12.5. So the overall survival objective was met at the pre-specified interim analysis favoring bemarituzumab. Regarding the overall survival in key subgroups, we found that overall survival benefit with the BEMA was consistent across the key pre-specified subgroups. The progression-free survival is significantly increased with the combination of BEMA with chemotherapy in comparison with other arm of the study. And it is found that the median progression-free survival is 8.6 with the combination of BEMA with chemotherapy in comparison with the placebo is 6.7, and the hazard ratio 8.7, so there is significant p-value. But regarding the objective response, as it is seen here, is almost similar between the two groups. So addition of BEMA to modified FOLFOX6 significantly improve the progression-free survival, but not the objective response. Now, the descriptive follow-up analysis, we found here that attenuation of the treatment effect was observed at the descriptive analysis after longer follow-up, with a median follow-up of 19.4 months. Now, the safety of the combination of BEMA with chemotherapy, of course, carries treatment adverse effects. The side effects and treatment are similar between the two groups, but it's more aggressive, high grade in combination of BEMA with the chemotherapy. And it's found that the interruption of IP, which is investigation product, is found about 28% with the combination of BEMA with chemotherapy. The adverse effects include ocular adverse effects mainly, in addition to other non-corneal events. And the grade 3 and more is found the combination of monoclonal antibody, which is 𝗕𝗲 with chemotherapy in comparison with the placebo group. The major ocular side effects, this decrease of the visual acuity and also corneal events. It is found these side effects occurs at almost 24 weeks of treatment, but it's found that visual acuity shows recovered sooner in comparison with the other corneal side effects. And as a conclusion, the Fortitude 101 met its primary endpoint of overall survival and key secondary endpoint of progression-free survival in patients with FGFR2b overexpression of at least 10% of the tumor cells. And the observed overall survival benefit attenuated at a subsequent descriptive follow-up analysis. Safety profile of bemarituzumab was primarily driven by corneal adverse events with associated decrease in the visual acuity. Visual acuity reduction was transient and mostly reversible. The result of this trial and upcoming Fortitude 102 trial will further characterize the benefit-risk profile of bemarituzumab in gastric and gastroesophageal cancer. And thank you.
So to the last presentation of the first session, Dr. 𝗘𝗦𝗀𝗪 consultant medical oncologist, will discuss the role of surgery in the advanced metastatic setting with the Periscope 2 trial. We'll have a discussion, and I think after that with a panel discussion, please.
Assalamu alaikum and good morning, everyone. Thank you for the invite. So I'm going to talk about the Periscope 2 trial that assessing the effectiveness of high-PEC therapy in patients with locally advanced and limited disease peritoneal metastasis. So we know that the gastric cancer, the most common site of metastasis, usually it is the peritoneal metastasis, and it differs from according to the histological subtypes. And overall, it carry a poor prognostic outcome. The standard treatment of care in this group of patients is systemic chemotherapy, including platinum-based, with or without immune checkpoint inhibitor. We don't have any level 1 evidence to inform us about the benefit of high-PEC therapy and cytoreductive surgery in this group of patients with locally advanced gastric cancer and limited peritoneal metastasis. So Periscope 2 trial actually trying to answer this question. So they included patients after getting the standard of care treatment of chemo, immune check plus minus immune checkpoint inhibitor, and for patients who didn't progress on therapy, they randomized them between the cytoreduction therapy plus high-PEC, this is the experimental arm, versus continuation of systemic treatment. So it's a multi-center phase 3, 2 arms, as I mentioned, and the patient selection included patients with locally advanced resectable gastric adenocarcinoma with limited peritoneal metastasis of less than 7 with tumor-positive cytology and absence of disease progression on systemic treatment. The primary endpoint of the Periscope 2 trial was the overall survival, and the secondary endpoint including the toxicity, quality of life, and progression-free survival. And this is the baseline disposition of the patients. As you can see here, 51 patients in each treatment arm, and about 44 patients on the standard of care systemic treatment can continue on the systemic therapy, and only 37 patients on the experimental arm entered into or randomized into the Periscope experimental protocol. 10 out of these patients actually at the surgery, at the cytoreductive surgery, was not included in the experimental arm because of the extensive peritoneal metastasis. The study was closed in September 2024 due to commissioned interim analysis for fertility with 100 patients included in the trial. This is the patient baseline characteristics. As you can see here, significant disease advanced stage. About 50% of the trial population has T4, and 50% of the trial population have positive lymphadenopathy, and more than 75% of them diffuse subtype. And as you can see here, this is the result of surgery and pathology, significant residual disease in the experimental arm. About 50 or 40% of the patient on the experimental arm had a residual T4 disease, and about 50% on the experimental arm using the high-PEC post and cytoreductive surgery had N3 disease, and a significant number had a residual disease in the peritoneum. And R1 resection observed in almost 1/4 of the patient in experimental arm. So it's a negative trial. As you can see here, the overall survival using the cytoreduction and high-PEC post-chemotherapy didn't show any overall survival benefit, either in the intention to treat population or even in the per protocol analysis. Yes, the hazard ratio is 0.7, but it's not statistically significant positive. So when it comes to the safety, also we can see here a lot of treatment-related side effects in the experimental arm. 45 serious adverse events using the high-PEC and cytoreductive surgery included in 22 patients, mainly leakage, anastomotic leakage and ileus were the most common treatment-related side effects. 3 treatment-related deaths reported in the experimental arm as well. So in conclusion, the systemic treatment plus minus immune checkpoint inhibitor in this group of patients with limited peritoneal metastasis, still it's the standard treatment of care. Adding cytoreduction or high-PEC therapy to this group of patients didn't show a significant overall survival benefit, with a median survival in the standard, median survival time in the standard treatment arm was about 16.6 months, while in the high-PEC and cytoreductive surgery was about 15 months. As per the protocol, we have to be careful in interpreting this data because, as I mentioned, the experimental arm, they limited the selection to patients with limited peritoneal disease of less than 7. So still, as I said, the combination of gastrectomy and cytoreduction high-PEC was associated with significant morbidity and even mortality, with high rate of mortality in this experimental arm. With that, this is the last slide, and thank you so much for your attention.
Thank you, Dr. Adali. I would like to invite all our presenters to the panel discussion. I will open the panel for question, but I will start with the first few questions, if you don't mind. If I might just start with the first question, Dr. Marwan, I think this is very impressive data regarding the Matterhorn. I think the initial summer in the ASCO, we were very excited to see the event-free survival. We were not very sure regarding the overall survival, but currently we are seeing very nice, clear separation of the curve. And as well, my question is, we are interested in seeing in the perioperative surgical candidate, PDL expression, positive or negative, did not actually show a very quite difference compared to the metastatic setting. So perioperative setting, PDL regardless, although the PDL negative were small population, still merit to have overall survival trend. How do you take that point from?
This is a practice changing data, and I think most of us even we were expecting this data somehow because there was an interim analysis that was favoring, and lots of us, I mean, have implemented maybe this approach even before the final overall survival data. But definitely, this takes the patients with metastatic gastric cancer, with resectable gastric cancer, to a whole different stage. And it tells you the importance of addition of immunotherapy for these patients.
So addition of immunotherapy, I believe there was some other trial in the perioperative setting. I think it was KEYNOTE-585, which addressed same question, but unfortunately it was negative. Yeah. So I think, is it due to the companion of the chemotherapy? It was a doublet at that time and included very small population of the.
I think FLOT has been the standard chemotherapy backbone for these patients, and I think this is what we have been practicing for years with FLOT. And now you have data with your own practice about adding the DARVA to this combination. So I think there's no doubt that this study is positive, yes, and it's practice changing.
Dr. Farouk, if I may.
If I can just a
Please.
follow-up question
Sure.
on the same topic. So very good data, of course, as you mentioned, but two things. What do you do with non-responders? Do we continue the same? And those who have complete response, they have very good outcome. Do we really need to continue adjuvant therapy, or maybe ctDNA may help? What do you think?
I think in general, when I use a protocol, I follow the protocol even in patients who have achieved a complete pathological response. And definitely, I personally would not stop. I would continue what I planned from the beginning. I would follow the exact protocol of
For
this
non-responders?
or non-responders also.
Maroon, how do you explain that in the, it's Said here, hello. How do you explain that in the frontline setting, what we have seen with DFLOT, that we have no difference between PD-L1 positive, PD-L1 negative, but when it comes to later line, then there is certainly more clear benefit towards the PD-L1 positive patients?
Yeah, I think this has been confusing to not only in gastric cancer, to in different cancers. I mean, some of them have correlated to the PD-L1, others have not. I think in the adjuvant setting, it's not as important as if I think in the metastatic setting, immunotherapy and PD-L1.
Maybe I can add to Dr. Saeed Rafi for breast cancer. You explained that as well, if you can. Similar situation, isn't it? You don't need PD-L1 for neoadjuvant, but you need for metastasis. We don't know. So I have a follow-up question on regards to IOs, because Dr. Farooq presented Skyscraper. Skyscraper has been disastrous in all negative studies. So TIGIT is not going anyway, but we see some signal in patients receiving adjuvant atezo only. Already we have Nivo approved in a slightly different setting where after chemoradiotherapy and surgery, if you have residual disease approved. So do you see still role of atezo in this patient group, or is it type of IO is a problem?
Yeah, thank you. I think you're right. Anti-TIGIT was a disaster. So I think Roche is pulling away from other tumors. I guess in the lung cancer, it was a negative study. Head and neck, it did not change the outcome. So this was a dual immune checkpoint inhibitor. So it was a hierarchical testing. So statistically, it was a negative study. But yes, you're right. If you look at the single agent atezolizumab, there does seem to be some signal and some efficacy there in terms of PFS as well as overall survival. So I think this needs further exploration rather than drawing any conclusion based on this.
Dr. Farouk, just to follow up on that question, as mentioned by Dr. Said regarding the TIGIT, I think we are seeing negative studies in the lung as well as in esophageal. So it drew the attention, what is the role of TIGIT? Is it actually synergistic to immune check inhibitor, or the hypothesis was not that much proved, and we are seeing much of toxicity? And regarding a follow-up regarding the role of IO, now we are seeing, I believe, in 3 decades an improvement in patient post-definitive concurrent chemotherapy with addition of immunotherapy. Now come the question whether we are considering in the future it will be, I think there is multiple phase 3 trial addressing that point, consolidation versus concurrent IO and definitive chemotherapy. Do you have any input for that?
Yeah, I think obviously this study in the adjuvant setting or maintenance setting did not really show any benefit of a single agent or combination. So we don't really have any data yet. Obviously, we have data in the post-operative setting. Patients who have chemo RT followed by surgery and residual disease, esophageal cancer, we have nivolumab approval. I'm not aware, I'm sure there are studies ongoing in other tumor sites with the concurrent chemo immunotherapy, but I'm not aware of any study in the esophageal setting.
If I can ask Dr. Mazen, so very nice data on the FGFR if you find the case, but we also have the approval of immunotherapy again.
Yes.
At least in bladder cancer, we know there is also good synergy between anti-FGFR and IO. Do you think that there may be even further improvement if we add IO to the mix?
No, actually, it is the same debate about the same point, that there is no inclusion of the BTL results or the immunotherapy in this study. But I think it will be, of course, beneficial later on, maybe in the later trials, inshallah.
They also withdraw the 102, Fortitude 102, that also has the IO in it, right? So there was a press release that they have stopped it now. So that is not
Toxicity.
showing anything either.
Well, we have seen synergy in other tumors. That's what I'm asking. It could be different tumors, but there is no question there is synergy between this antibody and IO. I mean, we see it clearly in bladder cancer.
FGF, actually, FGFR2b, it is expressed in a number of cancer, not only in gastric and
Right.
esophageal cancer, in lung, esophageal, others, but it's found that almost 30 to 38% of gastric and gastroesophageal cancer showing overexpression of this receptor. So there will be, of course, more trials about other sites of cancer.
And maybe
You have a question?
one more for
I have
Dalia.
for Dr. Dalia. I have a question because we have our surgical colleague Dr. Faraj as well. So what's happening with the Dr. Dalia with the high pack? I mean, how many times we have to do a negative study? Where do you think is the problem? And obviously, we need to have some opinion from our surgical colleagues as well. So what do you think moving forward? What to do for those patients? And every time we have, EOS or other meetings, is always, yeah, some patient may benefit, but we come back again with negative trials, one after
I
other.
think to have such a trial, randomized phase 3 trial, to answer the question of high peak and for limited peritoneal metastasis, this is very important for us as a medical oncologist, and in the tumor board as well. To have a baseline diagnostic laparoscopy is very important. Again, it's highlighting the importance of doing the laparoscopy, diagnostic laparoscopy, staging laparoscopy in this group of patients, because this is the most common site of metastasis. Honestly speaking, from my personal perspective, I don't believe in the high PEC, and this trial actually confirmed the negative outcome in this group of patients. I'm not sure. We need to hear from the surgical team what is their intake of this trial.
Thank you. Basically, my opinion on HIPAC, which I've done a lot back when I used to work in Lebanon at the American University of Beirut, patient selection is the most important factor. You can have someone who has a PCI of 2 and 3, you operate, you do HIPAC, you try to make sure you didn't even leave a single cell. After 2-3 months, blown up, recurrence, full metastasis. And this apply to other. So the biology of the disease, the original surgery, because most of the people who underwent HIPAC are people who had surgery and they recur and then they stabilize, and then the decision after tumor board to go for more cytoreduction. So in my opinion, okay, I know most of the studies has been showing negative results, the colorectal, and recently there have been also HIPAC for gallbladder cancer, and also it didn't show any benefit. But still, patient selection is a very important criteria because some of the patient will benefit from HIPAC.
The histology, I think histology, biology, like the signet cell ring, Linitis plastica, those are bad prognosis and HIPAC.
To add also, I also remember that a young patient, also Iraqi, who had Linitis plastica. We did total gastrectomy and extensive surgery. I mean, but unfortunately, I remember after 3 months, the patient recurrent very aggressive.
Thank you all. I think we now conclude the first session, and I would like to thank all of the presenters for their valuable input. And just only we'll start by Dr. Marwan, so I'll just present.
Thank you so much indeed for. So now, obviously, my absolute pleasure to introduce Professor Walid Faraj, who is the next moderator for moderating the lower GI cancer. Professor Walid doesn't need any introduction. He's a very eminent surgeon currently working at 𝗕𝗲𝗀𝗃 Hospital here, professor of surgery at American University of Beirut as well. Thank you. Please.
Good morning, and I would like to thank the organizer for inviting me. It's always a pleasure to be with my dearest colleague and friends. So we're going to start the second session, which is about the lower GI cancer. We're going to start with Dr. Humaid, who I think he has recorded talk because he's currently in Dublin, adding to his degrees one more, and I hope he will still have walls to hang them. Anyway, we are always super proud of Dr. Humaid. So he's talk about the results of the randomized PERISCOPE 2 trial. Can we start playing the talk, please?
Assalamu alaikum, and I'm sorry for not being able to join you in person, but the only good thing about recording a session that I don't have to take questions from Dr. 𝗘𝗲𝗀𝗳. So today I'll be highlighting or talking about ctDNA-guided adjuvant chemotherapy de-escalation in stage 3 colon cancer, which is the de-escalation arm of the dynamic 3 trial presented by Dr. Jane Tai from Australia, who's an expert in this field. This was her disclosure and background. We all know that 3 to 6 months of oxaliplatin-based chemotherapy, adjuvant chemotherapy, is standard of care for patients with stage 3 colon cancer. But as we all know, potential side effects, toxicity, neuropathy, and also uncertain benefit of any individual patient still remain a problem or an issue in stage 3 colon cancer. And definitely we have high risk and low risk. And that's why ctDNA may help us in making these decisions for these patients. So Dynamic 3 explores ctDNA-informed management stage 3. It has armed the ctDNA positive, and this was the escalation arm, which was presented in ASCO 2025, which are not present today. And also we have the post-operative ctDNA negative, which evaluated the treatment de-escalation versus standard of care, which is presented in ESMO 2025, which is the presentation today. So in Dynamic 3 trial, this is the design where patients with stage 3 colon cancer complete resection, and they are fit for fluoropyrimidine chemotherapy-based treatment, and also they had staging within 12 weeks and negative, and also they have adequate tumor tissue for less than 6 weeks post-operation, and no synchronous colorectal cancer. Were randomized after the tumor-informed ctDNA analysis 1-to-1 to either ctDNA-informed management versus standard management. Standard management is simple, which is actually treatment per clinician choice, blinding to ctDNA results, so the clinician did not have access to the ctDNA result. And also we have ctDNA-informed management, which was either ctDNA negative, and these patients had de-escalation, or ctDNA positive, and these patients have escalation. And again, we'll discuss today the de-escalation arm. And the de-escalation actually had very clear treatment pathway. Patient was supposed to get 6 months by 5-fluoropyrimidine. They went to chemotherapy, or 3 months. Patient who had 3 months of oxaliplatin, they went to less chemotherapy with a 3 to 6 month fluoropyrimidine. Patient who 6 months oxaliplatin plus 5-fluoropyrimidine, they went to 3 months oxaliplatin-based chemotherapy, or 6 months of the fluoropyrimidine. So clear de-escalation strategy has been planned for patients who are ctDNA negative in the Dynamic 3 trial. And the primary endpoint was 3 years recurrence-free survival. Secondary was treatment adherence and safety as well. The statistical consideration for the ctDNA negative cohort is very important to understand because this study is tissue treat analysis. So all eligible patients who were randomized and had post-op blood draws and analysis to occur would complete 3 years of recurrence-free survival. For information is more than 99%. And for the sample size, statistics was 750 patients would provide 80% power to show non-inferiority of the 3-year recurrence-free survival rate with a margin of 7.5. Please remember this 7.5 because this is very important when we discuss the result. Then inferiority accepted a lower bound of the one side, it's 97.5% of the confidence interval difference at 3 years did not cross 7.5%. Again, just a reminder, the study will cross 7.5, so it's also important to remember this, the non-inferiority design of the study. Assuming 75% of the patient will be ctDNA negative, total 1 patient to be randomized in this trial. So this is subject to disposition of the dynamic 3, 1,200 patients randomized, 666 institutions from October 2017 to April 2023. So we have almost 6 years. And the ctDNA informed had more than 500 patients, and the standard management had 500 patients. And ctDNA negative had 353 patients, and the ctDNA negative had 349 patients included in the final analysis. When we look at the baseline characteristics of the ctDNA negative, overall they were balanced, but also we have to highlight that they were a little bit more right-sided patient on the ctDNA informed de-escalation arm. Also, the clinical risk of T4 and N2 were slightly higher in the standard 35 versus 31%. The mismatch repair was slightly higher also in the de-escalation arm, and the planned standard of care with different subsets were also highlighted in this table. When we look at the chemotherapy received, when we look at the 3-month or 6-month of the 5-fluoropyrimidine, patient had more in the ctDNA informed de-escalation, so less oxaliplatin-based chemotherapy was used in the ctDNA informed de-escalation. But when we look at the ctDNA informed de-escalation, the oxaliplatin doublet was actually used less compared with the standard management. This is just also the treatment duration, which was almost similar between the 2 arms. Completed treatment cycles, 90% almost complete ctDNA informed de-escalation versus 82, so slightly lower in the standard treatment completed their treatment. When we look at the side effects, there were more side effects, treatment-related hospitalization, 13.2 in the standard arm versus 8.5. When we look at the grade 3 or grade 4, 6.2 was in the de-escalation arm versus the standard management, where they had more side effects with grade 3 and grade 4 with significant p-value. Looking at the result, recurrence-free survival, when we look at standard of care, 88% had recurrence-free survival versus 85.3 with the absolute difference of 2.8%. And unfortunately, the absolute difference in 3 years did cross the lower end bound, cross the 7.5 non-inferiority margin. So the result or the recurrence-free survival or the non-inferiority was not, were not able to prove in this trial. When we look at the recurrence-free survival by clinical risk, so we have low risk and we have high risk. We look at the low risk T1 to T3 plus N1, 93.2 versus 91. So the absolute difference was 2.2. On the clinical high risk T4 into the absolute difference actually was 5.8%. So there was more, pronounced difference in the high risk population versus the low risk. When we look at the ctDNA negative versus ctDNA positive, and also we look at the burden that, how high was the burden of the ctDNA. When we look at the negative, the patient had recurrence-free survival much better. And this actually slide just prove the prognostic value of ctDNA, the higher the concentration of the ctDNA in the patient or the subject, the higher risk of the recurrence. So the higher the concentration, the lower the lower or the higher risk of the recurrence they have. As you can see here, the concentration as we go higher, the recurrence goes down as well, because higher actually. So the conclusion of this trial for patients with ctDNA negative stage 3 colon cancer, the recurrence is overall is low, and recurrence survival was around 87% at 3 years. The ctDNA-informed treatment de-escalation was feasible with high adherence up to 90%. Marked reduced oxaliplatin exposure 88 versus 34%, as we've seen the slides. And also there's better safety profile, fewer treatment-related hospitalization and grade 3 adverse events. Non-inferiority and unfortunately versus standard care was not confirmed, though outcomes were very close. The 3 years recurrence-free survival, 85 versus 88%, particularly in the low-risk T1 to 3N1 disease. And this could confirm risk-benefit discussion for individual patient, and ctDNA-informed de-escalation strategy warrant further investigation. So how do I interpret this, and how do I use this actually try to inform my patient? Definitely, I will not use a standard to de-escalate treatment, but for patients who are stage 3, patients who are actually low risk but high risk, and patients actually are very keen and are not very keen, they're very keen not to get chemotherapy, or they're keen to reduce their chemotherapy exposure, I will consider discussing with them the de-escalation if they are low risk only. High risk, as we've seen that, I have concern that, maybe this is not the best option. So I will keep this for low risk T1 to T3N1 disease for individualized patient and not for all patients. And this is the acknowledgement from the author. And this is a paper published in Nature Medicine, if you would like to have access to it. And with this, I would like to conclude, and thank you so much for your attention. Wassalamu alaikum wa rahmatullahi wa barakatuh.
So we thank Dr. Ḥumayd. Our next speaker, Dr. Syed Karim, who will be talking about the final results of the Pegasus trial.
Hello, good morning. Thank you, Dr. Syed Rafi, the best of ESMO team and EOS for giving this opportunity. Absolute pleasure to be in front of such a distinguished audience. So I've been tasked to talk about the Pegasus trial, which is a post-surgical liquid biopsy-guided treatment of stage 3 and high-risk stage 2 colon cancer patients. And this was the final results of this trial was presented in Berlin this year. Let me just. How do we move it? Thank you. So, as we all know, for high risk stage 2 or stage 3, we give adjuvant chemotherapy, and there is a school of thought which wonders whether we are over treating such patients, and ctDNA is a strong marker for relapse. So this trial, what they were looking is to see if it is feasible to decide on the adjuvant chemotherapy based on ctDNA and escalate if the patients are ctDNA positive, and then de-escalate if they are ctDNA negative. So the outlook was such that the patients had surgery. They were all stage 2 high risk, more specifically T4N0, stage 3, or microsatellite stable colon cancer. And they had the initial ctDNA done at 2 or 4 weeks after surgery. And then if it was ctDNA positive, they went in the top arm, which meant they had 3 months of CAPOX. And then after the end of 3 months of CAPOX, further liquid biopsy test was done. If it was ctDNA negative, then they were de-escalated to capecitabine. And if it was ctDNA positive, they were escalated to FOLFIRI for 6 months. And if they were de-escalated, then there was ctDNA test done after cycle 1 of CAPE, and subsequently in the follow-up arm, 3 months, and 6 months later. If you go on the bottom of the chart, then those patients were ctDNA negative. They had 6 months of capecitabine, and at cycle 2, day 1, they tested liquid ctDNA again. And if it was ctDNA positive, they were escalated for 6 months of CAPOX. And if they were ctDNA negative, then just surveillance with periodic monitoring of the ctDNA. So moving on to the trial design and endpoint, the primary endpoint was relapse rates in patients with 2 consecutive negative ctDNA tests at 2 years. And the target 2-year recurrence-free rate was more than 92%. So what they figured out is that if they check for 134 ctDNA negative patients, and if there was less than 14 relapses, then that would make the study positive for them. And the secondary endpoint was 2 years and 3 years disease-free survival, 3 to 5 years overall survival, the feasibility of treatment, safety, and quality of life. And what they did, they benchmarked this with the TOSCA trial. So this is the consort for the Pegasus trial. 156 patients were enrolled, 153 were screened with liquid biopsy, 16 became ineligible because of stage 4 disease, DPYD mutation, or MSI high. So they were left with 137 patients, 2 actually withdrew, so it became 135. This study was done in between July 2020 and July 2022, so over 2 years, with a median follow-up of 42 months. 135 patients were treated. There was 100 of them were ctDNA negative, and 35 were ctDNA positive. Because they planned for 134 ctDNA negative, they could only recruit 100, so the power was a bit reduced. Now, if you go on to see on the right side, the patient demographic, so just want to highlight the pathological T stage. If the T1, T2, there were about 18 patients. Of that, 16 were ctDNA negative, and 2 were ctDNA positive. And in T3, T4 stage, 117 patients. Of that, 84 were ctDNA negative, and 33 were ctDNA positive. And if we go by N stage, then N0, there were 14 patients. 8 of them were ctDNA positive, and 6 were ctDNA negative. And subsequently for N1 and N2, in N1, there were 88 patients, 71 were negative, and 17 were positive. And N2 so also had 23 negative and 10 positive. So good distribution, less in N0, more so in N1 and N2. And if you go by the staging, then in the low risk, in the high risk stage 2, where T4 N0, 6 patients were negative and 8 patients were ctDNA positive. Whereas stage 3 low risk, 57 patients were negative and 15 were positive. And this is just to mention that ctDNA status after surgery, about 26% patients were ctDNA positive after surgery, and around 74% patients were negative. And in the right side, you can see the graph, which I've already mentioned about the individual stagings. So now moving on to the primary endpoint, 100 ctDNA patients were recruited, 12 had relapse, 2 local, and 10 distant within 2 years. So the 2-year recurrence-free rate was 88%, and 90% CI was 81 to 93. And because they could only recruit 100 and not 134, so the power was a bit less. But the target of 92% was crossed, with the upper CI being 93%. So this just suggests that this is clinically adequate despite reduced power. Moving on to disease-free survival and overall survival, this just reiterates that if a patient is ctDNA positive, marked by the red line, then there's almost 3 times more chances of disease-free, so there's 3 times more chances of recurrence and also overall survival. And this is with a hazard ratio of 2.71 for disease-free survival and 3.11 for overall survival across a median of 42 months. Now, this is quite interesting. If you see the secondary endpoints, the common site of relapse was liver, lung, peritoneum. But what was important is that can the ctDNA suggest the site of the metastases, or can it pick up the sites of the metastases? On the right side, if you see the patient who had relapsed in the liver, 13 patients, and of that 13, 85% was picked up on ctDNA. But if you go on the right side, those who had lung metastases or peritoneal metastases, the ctDNA could not pick up, and we had to rely on imaging to pick recurrence. And what was useful to know that the median lead time was 9.1 months in favor of ctDNA, which suggests that they pick up recurrence earlier than radiology. And this is to just show that the ctDNA post-surgery, on treatment, or end of treatment is quite prognostic, with those patients who were having ctDNA positive after the end of treatment will almost have 6 times more chances of disease recurrence compared to ctDNA negative. So it's important to monitor ctDNA, often and not just one-off random. Now, this is a swimmer plots which shows the journey of each patient's and their ctDNA. And what they did, they divided this into 5 clusters, if you see on the right side, with persistent negative, sustained clear, transient clear, and persistent positive and converted positive. What this essentially shows that those patients who had ctDNA persistent positive were about 5 to 6 times chances more likely to have relapse. And this is, as I said in the beginning, that this was benchmarked with TOSCA trial. Why TOSCA? Because TOSCA trial was a similar trial which reported disease-free survival outcomes for those patients who received adjuvant chemo in a stage 2 high risk and a stage 3 high risk without ctDNA, without ctDNA testing. And in this trial, they wanted to check whether they can match the outcome. And this showed similar efficacy and reduced toxicity because we were giving less chemotherapy. So overall, less harm and not much compromise on the efficacy. If you see the disease-free survival had the hazard ratio of 0.89 with a p-value of 0.669. So to conclude, adjuvant ctDNA is feasible. It looks promising. It might help us to optimize the adjuvant chemotherapy, which in turn will cause less toxicity and also less financial toxicity. And there are trials looking at it, so watch the space. Thank you for your time.
Thank you, Dr. Syed. Our next speaker is Dr. Hassan Azad. He will be talking about the comparison of outcome in clinical trials of locally advanced dMMR colon cancer data from the Foxtrot and NICHE-2 trial. Dr. Hassan.
Assalamu alaikum, good morning. Glad to see a good turnout today. Usually day 2 is a little harder to keep people going. Again, thanks for the organizing committee, Dr. Saeed in particular. This is really well organized and topics excellent for discussion. So my task, we're going to move a different subject, the so-called deficient MMR colon cancer patients. As you all know, we had good data on rectal cancer, and colon cancer was slightly behind. And, giving immunotherapy-based regimen was not yet popular in these so-called locally advanced deficient MMR. So this is a combined sort of collaboration between the first author from University of Leeds, and of course, Dr. 𝗘𝗦𝗀𝗳 is well known from the Netherlands that she pioneered the niche studies. So what we know about deficient mismatch repair, first of all, it is not very common, but we always need to check for it, because if we find it, it's a really different ball game, as I will show you. Certainly, there is hypermutations in these tumor types. And historically, the standard treatment has been to do upfront therapy followed by adjuvant chemotherapy, usually an oxaliplatin-based regimen, in addition to fluoropyrimidines. And then, as I mentioned, in metastatic setting, certainly the use of IO therapy, as the next talk also will be on that, has changed the paradigm, and it looks like we don't need any chemotherapy with it. So certainly single agents or doublet immunotherapy has been the standard. In the adjuvant setting, obviously, we always lag behind, but we had seen also so-called atomic trial that showed us DFS benefit when you add atezolizumab to adjuvant chemotherapy in those deficient MMR. And you can see the curve, and the 23% still had recurrent disease despite 6 months of adjuvant chemotherapy. And we always know the stage 2 data that if you have dMMR, actually 5-FU based chemotherapy, not just not helpful in a way, it was even negative numbers. So we always have hesitancy between giving chemotherapy to these deficient MMR in the adjuvant setting, at least in the stage 2. In stage 3, because the risk is higher, we always have given the chemotherapy anyway. But you can see the data is inferior also, because you have a higher rate of recurrences with chemotherapy alone. So the idea of neoadjuvant IO therapy, like I said, started with the metastatic setting, moved to the neoadjuvant in those locally, so-called locally advanced colorectal cancer. And we know that when you give treatment in the neoadjuvant, especially IO therapy, you actually have a better results, and mainly because we know when the tumor is in place, you have more antigen, you have more chance to have a better response to immunotherapy. And this was shown clearly in the NICHE-2 study, that even a short-term treatment can result in very high efficacy. The implementation has been limited to patient selection and lack of comparison to standard arm. So most of these trials have reported DFS benefit compared with upfront surgery. You can see on your right side the result of one of the studies, so 2 of the studies there. And you can see the forest plot, 5-year disease-free survival, all pointing to favoring neoadjuvant therapy versus upfront surgery. But again, these trials did not answer the full question. We don't have further data on survival. There is a trend to improvement starting with neoadjuvant chemotherapy in this case. So Foxtrot and NICHE-2 trial designs, you can see them side by side. The Foxtrot took obviously the locally advanced disease, no metastasis, and they tried to do 2 things here, surgery upfront followed by chemotherapy in the green, or pre and post-op. So they gave 6 weeks of pre-op, then surgery, then 18 weeks of post-op. Again, these are in the locally advanced colon cancer. The NICH2 took a different approach in this deficient MMR, MSI high, and they gave, in this case, Epi-Nivo, 2 cycles followed by surgery. So the whole thing took 6 weeks. So here we want to compare these 2 trials in terms of choosing the deficient MMR in the Foxtrot trial, and then try to compare it to what we saw with NICH2. So patient obviously had to be confirmed to be DMMR in the Foxtrot. And of course, the NICH2 had the clinical criteria also trying to match the Foxtrot. The endpoints were 3-year DFS and pathological response. So 3-year DFS historically has been chosen as a good correlative to overall survival in colorectal cancer, at least. So that's why, and it's easy to measure as a 3-year DFS. Again, this is a study population. Out of 1,000 plus patients on the Foxtrot, 867 were proficient, so those who were excluded obviously were interested in the deficient MMR, and we had 185, and of those we had 117 perioperative chemo, and 68 had the traditional upfront surgery and then adjuvant chemotherapy. In the NICH2, we had 115 patients enrolled, and then a final analysis, there were 94 patients after excluding the T2 stage. Patient characteristic, we can see in the Foxtrot, the T4 lesions were 35% versus 76% in the NICH2. So much more, obviously, T4 lesions, and the same for T3 the other way around. N0, 19 versus 25, and the positive N were the majority, 80% and 75%. So trying to match as much as possible between 2 different trials. So the primary analysis, again, 3-year disease-free survival. We all remember the 100% because we don't see 100% in many trials, except on those niche trials. So if you give neoadjuvant Epi-Nivo, in this case, you can see at 3 years, nobody had recurred 100%. Looking at the Foxtrot design, and after choosing these patients, we saw an 80% DFS. Again, remember, this is chemotherapy-based for the deficient MMR. The log rank p-value less than 0.001. And there was no difference observed in DFS between different strategies in the Foxtrot, meaning perioperative versus adjuvant therapy only. So it didn't make a difference, although the number of patients, I think, becomes smaller to make a definitive conclusion. So disease-free survival in the straight to surgery, again, you can see 100% in the NICH2, 80.8%, same p-value, no difference really, whether you do perioperative or adjuvant. The response to neoadjuvant treatment, you can see a huge difference here. With immunotherapy in those deficient MMR, we see a complete response of 72%. So that's still an amazing number. Didn't reach the 100% in rectal cancer, as we all know with the data from Memorial Sloan Kettering. But still, almost 3/4 had a complete response, and another 25% had marked response, as we say. In the chemotherapy, the Foxtrot perioperative, complete response is rare, only 4%. And, you can see a big difference in the response rate overall. Looking at the different characteristics of the tumor, again, you can see the comparison between NICH2 and Foxtrot approach. Pathologic stage or lymph nodes or R status. So in conclusion, again, tried as much as possible to match for comparably selected trial patients, all with deficient MMR, locally advanced colon cancer. There's no question in our mind, I guess, neoadjuvant Ipi/Nivo resulted in statistically significant and clinically meaningful improvements in the long-term outcomes. No recurrences in the niche 2, regardless of the risk of the disease and on presentation. Very low rate of complete responses with neoadjuvant chemotherapy from the Foxtrot trial, and definitely shorter treatment duration in niche 2. So clinical staging identified again poor prognostic dMMR patients in Foxtrot. So still clinical stage matters. The higher your stage, there is higher gain with neoadjuvant IO in those who have more locally advanced disease, the clinical T4 lesions compared to chemotherapy. 20% recurrence rate in T3 patients, still clinically relevant, again with the chemotherapy. So again, bottom line, this data supports the use of neoadjuvant IO therapy in these locally advanced colon cancer. More data on dMMR was presented at ESMO. Also, this is one of them, the imaging biomarkers to predict outcomes in locally advanced colon cancer from the Foxtrot trial as well. By this, I think the last slide, acknowledgement to patients. So thank you for listening. Is this for somebody? Oh.
Thank you, Dr. Hassan. Our next speaker is Dr. Ali Shamsuddin, who will be talking about the new results from the CheckMate HHW. Dr. Ali.
So, good morning. First of all, excuse my accent because I have a little bit strong French accent, I think. I'm trying to practice it. So I'm very honored, and it's my pleasure to be here with you to speak about the new data, updated data from CheckMate Trial 8HW, comparing nivolumab plus ipilimumab versus nivolumab monotherapy for MSI high mismatch repair deficient metastatic colorectal cancer. As you already know, MSI high dMMR metastatic colorectal cancer, it's a rare tumor, 5% approximately of metastatic colorectal cancer. They are well known because of their high tumor mutational burden. They have a rich neoantigen repertoire, and this is why it makes sense to give immunotherapy for this setting, especially that they have a high density of CD8 positive inflammation, infiltration, and tumor microenvironment. So it has already been shown in the first phase 3 CheckMate 8HW trial result that in patients with centrally confirmed MSI high dMMR metastatic colorectal cancer, comparing nivo-ipo to chemo or to nivo monotherapy, respectively superior PFS versus chemo in the first-line setting with a HR of 0.21, superior PFS also versus nivo across all lines, with the same safety signals as usual when we use immunotherapy. So this led to the approval of nivo-ipi as a first-line treatment in patients with MSI high dMMR metastatic colorectal cancer globally. It was a practice-changing trial. And here I'm going to report for the first time the result for the pre-planned PFS final analysis for nivo-ipi versus nivo first line, and the first interim analysis of OS for nivo plus ipi versus nivo across all line. And additionally, we are going to present some extended follow-up data for other efficacy endpoint. This trial has a follow-up approximately of 4 years, so we have mature data enough in this setting. So the study design is a multi-center open label phase 3 trial. It was conducted in 128 centers across the world, or over 23 countries, I think. Eligible patients were surgically confirmed unresectable or metastatic colorectal cancer. MSI high or DMMR status was by local testing then centrally confirmed by EHS or PCR. ECOG was 0 or 1, immunotherapy naive patient. Certification was done on 0 versus 1 versus more than 2 line, and also decidedness were taken into consideration. Patients were randomized in 2-to-1 classical setting with monotherapy Nivo arm versus Nivo EP versus chemotherapy. Investigator chose plus minus targeted therapy. So we had 2 dual primary endpoint. All the MSI high, as I already said, and DMMR status was centrally confirmed. The dual primary endpoint were assessed also by BICR for PFS Nivo EP versus chemo in first line, PFS also for Nivo EP versus Nivo across all line, and secondary endpoint in patient also centrally confirmed was PFS, response rate, and even safety. The data in April 30, 2025 was cut off with a median follow-up for the first line patient of 50 months and across all line for approximately 55 months. So this is a consorted diagram among the 839 patients who were randomized. We had 202 patients who received Nivo plus EP in the first line. Among these, 171 were centrally confirmed and received Nivo EP in the first line, and they were the basis of the primary efficacy analysis, compared to 201 patients who received Nivo in the first line. Among them, 170 were included in the analysis of the efficacy by central confirmation. So we already talked about the statistical analysis plan and the other studies before me. So this is important to understand because whenever we talk about hierarchical multiplicity statistical analysis, we need always to confirm the prior endpoint to be able to keep and to continue with this following endpoint. And alpha is going to be allocated by reducing little by little. So we need to subtract from the alpha, the main alpha, the alpha we are giving to the other, to the prior key endpoint. This is why if you look at the secondary endpoint for the analysis of the PFS for Nivo EP versus Nivo first line, we have the boundary of significance for 0.038 and not the usual 0.05. So the baseline characteristic is a classical consistent balanced well population. You have on your left side the first line or randomized patient cohort who represent the safety cohort, and on your right the first line centrally confirmed, which represent the efficacy cohort. So all the criteria characteristic were well balanced across age, sex, region, ECOG, sidedness, PD-L1 status, and even mutational status. Sorry. So the PFS first line Nivo plus EP versus Nivo in centrally confirmed patient. First of all, you can see that the curves are separating very early. So we have a rapid response, and it's durable during the timeline with a PFS absolute improvement between 10 to 13% across the plateau. The HR for the combination arm versus Nivo was 0.69, which represent 31% reduction in progression or death. The median PFS was not reached in the combination arm. So in patients with centrally confirmed MSI DMMR, metastatic colorectal cancer, the first line Nivo plus EP demonstrated clinically meaningful improvement in PFS versus Nivo. But as you can see, the p-value here missed by some very small digit the significance of 0.38 because it's equal to 0.041. But still, clinically, it's significant, meaningful. So the data in this setting is really interesting to be taken into consideration. If we look at the subgroup analysis, again, we don't have any difference. The median PFS between the two arms and the combination arm, I mean, was consistent across all over the categories, and mainly the mutation status, or even, you know, the poor prognostic population like old patient or liver mets or peritoneal mets still benefited from the combination arm. And if you look, because I'm always interested in the BRAF population, if you look at the BRAF status mutant, you can clearly see that even these very poor risk population took benefit from the combination with a HR of 0.72, which is the best benefit between all across the mutational marker. For the response rate, we have clear good response rate for the combo arm, 73 versus 61, with a good complete response, better than the monotherapy, 35 versus 31. And clearly you have less earlier progressor with 11% in the combo arm versus 16%. The median time to response was always less than 3 months, and the median duration of response was not reached. So in patients with centrally confirmed MSI, there were a clinically meaningful improvement in OR and response rate, higher CR, and lower progressive disease rate. So these data were consistent with those observed in the first-line or randomized population by local testing. For the safety of first line, we have the classical side effect of immunotherapy, mainly less than 1% treatment-related deaths. We have a little bit more serious treatment-related adverse effect, with 19% any grade versus 10% for the nivo monotherapy. And the usual reported common effect with pruritus, diarrhea, hypothyroidism, asthenia, and fatigue. So for the OS nivo plus ipi versus nivo across all line, this is a descriptive analysis because the data is not mature. You can see that the median OS is not reached in the combo arm with a HR of 0.61 and the reduction of deaths of 39%. For the updated PFS, I'm sorry, I'm sick. This is why I'm having this problem. Nivo plus ipi versus nivo across all line in centrally confirmed patient. We have again a clear separation, early separation of the curves with an absolute difference in PFS between 10 to 13% across all timeline of the curves. So in patient with centrally confirmed MSI high, DMMR metastatic colorectal cancer, the combination arm continued to demonstrate clinically meaningful improvement in PFS versus nivo across all line. So this is also consistent with those observed in the all randomized population by local testing. So in summary, first-line nivo ipi demonstrated clinically meaningful PFS improvement versus nivo in patient with centrally confirmed MSI high DMMR metastatic colorectal cancer with a 31% reduction in the risk of progression or death. It's a clinically meaningful improvement in ORR, also higher CR and lower progressive disease rate with the combination arm. So the safety signals were the classical one, and with the longer follow-up, we didn't see any new side effect. OS data also, even though it remains immature, it favored Nivo-EP versus Nivo across all line in patients with centrally confirmed MSI high dMMR metastatic colorectal cancer. And with longer follow-up, Nivo-EP continued to show clinically meaningful PFS benefits versus Nivo across all line. So these new results further support the combination dual immunotherapy Nivo-EP as a standard of care option for the first line of MSI high dMMR metastatic colorectal cancer. Thank you.
Thank you, Dr. Ali. Our next speaker is Dr. Sonia Osman. She will be talking about the primary overall survival analysis from the randomized open-label phase 3 Stellar 303 study.
Bismillahirrahmanirrahim. Good morning, everyone. Assalamu alaikum. I would like to thank the organizer for keeping us always and every year aligned with the ESMO data and the review. And I would like also to thank the eminent speakers before me. So without delay, I will discuss today a phase 3 trial that is the Stellar 003. Trial that was actually done by Anwar Saeed. It's not Saeed Rafi, but Anwar Saeed, not to be confused. Anwar, okay. Okay, so I'm sorry, female. Okay, more information. So the background of the study, in fact, is that it's a phase 3 trial, which is combining the immunotherapy with the actually tyrosine kinase inhibitor, and that's improved the overall survival for metastatic colorectal cancer who does not have actually deficient MMR or high MSI. This is in the proficient MMR. And this is the first time we have combination of immunotherapy with tyrosine kinase inhibitor, which is a new molecule. And this new molecule, in fact, is called zenzalantinib, Zanzibar, zenzalantinib. This is how I try to remember it. It's a novel, small molecule tyrosine kinase inhibitor, multikinase, including the TAM kinase, the MET, and the VEGF receptors. So it actually inhibits these kinase with the zenzatinib and might improve responsiveness combination with the immunotherapy treatment. So it's demonstrated improvement in anti-tumor activity and manageable toxicity with the molecule, which is zenzalantinib, and atezolizumab combination, comparing to zenzalantinib alone in patients with metastatic colorectal cancer. So this actually, we will present the primary overall survival analysis of the randomized open label phase 3 Stellar 003. So this is the study design. It's randomized 1-to-1. The population study actually should be more than 18 years. Performance status 0-1, documented not to have MSI high or dMMR, and should be metastatic colorectal cancer that radiologically has progressed or have been refractory to prior standard of care therapy, including all kind of population eventually with BRAF mutations, and those who have been intolerant to standard of care therapy, including actually all approved standard of care, fluoridipine and irinotecan, oxaliplatin and anti-VEGF treatment, antibodies, and anti-EGFR treatment also for the RAS wild type, and BRAF inhibitor, as I mentioned earlier. So it was randomized 1-to-1. The first arm, as you can see, the number was 901, big number of patients. The first arm was treated with atezolizumab and zanzalintinib. The dose of zanzalintinib is 100 milligram daily, and the dose of atezolizumab is the standard dose, 1,200 every 3 weeks. And the second arm, actually comparison, is regorafenib with the standard dose, which is 160 milligram daily, 3 weeks on and 1 week off for 28 days duration. So the cycles. So stratification factors are the geographic region, Asian or all over the world, RAS status, wild type versus mutant, and presence of liver metastasis. The dual primary endpoint, which is very important, this is the first time we see like a primary endpoint in such patients treated already heavily with the other standard of line. Overall survival and tend to treat population was actually dual primary with the overall survival in patients without liver metastasis. And key secondary of endpoint was overall response rate and PFS and the safety. So with that, we have the screened patients. You can see that the population that was screened was a big population, 1,325, randomized 1-to-1. But in the screened population, we had actually 424 patients who screened were failing the screening, as you can see, and did not meet the eligibility criteria for this screening. And the rest of the randomized patients, as I mentioned in the trial, was a number of 901. The first population, that was 450, treated with atezolizumab and zanzalintinib, actually. In fact, it was 451, safety population 446, and the patient who were still ongoing treatment was a number of only 22, and discontinued all study treatment, as you can see here, was a big number, which was 424 in the dual treatment with zanzalintinib. And as you can see also in the regorafenib arm, the treatment ongoing population were 10 comparing to 22, and discontinuation treatment was 424, also comparing to the dual treatment. Adverse events in the zanzalintinib arm was 98 comparison to actually regorafenib, that was 331, and lack of clinical benefit was actually 1 patient, and adverse events in the regorafenib was 77 patients. The patient request was 14 for the dual therapy with the TKI and the atezolizumab, and patient request in the regorafenib arm was 12. And the last follow-up was 1 patient for the zanzalintinib arm. So with that, the baseline characteristics well balanced between both trials. As you can see here, male, females, time to randomization for both arms, as you can see, were equally balanced. And you can see for the RAS status wild type, BRAF status also was equally balanced and distributed, and prior systemic therapy for the patients, whether 5-FU, irinotecan, and oxaliplatin, and any prior anti-VEGF therapy was also well balanced between both arms, and any prior anti-EGFR antibodies also was equal between both trials. So here we have the overall survival analysis and tend to treat population. As you can see, it is interesting to see that the curve separated already at 3 months and a half, almost 4 months, and they continue to separate. The overall survival was actually with a hazard ratio of 0.8 and the p-value that was 0.045. It's interesting to see that for this population that were heavily treated with other arms, standard arms, when you combine the atezolizumab with the zanzalintinib for pMMR population, you can see almost at 24 months separation, 20% comparing to 10% of this population that express overall survival. So this is interesting because this is heavily treated population already. So with that, we consider that this is positive. And then in the interim analysis, Also, we can see that the overall survival and intent to treat population was positive, with the median overall survival that was 10.9 comparing 9.4. You're going to tell me it's only 1 month difference, but when we are talking about population that have pMMR and comparing two arms, which is regorafenib and multikinase inhibitor with immunotherapy, this is the first time we combine immunotherapy with multi-TKI. It's interesting to see that there is a median overall survival separating by 1 month, and also we have the overall survival in the subgroup population. If patient had RAS status, whether wild type or mutant, you can see here, like the combination with the immuno and the zanzalintinib showed positivity in the overall survival in all subgroup of population. Eventually, in the liver metastatic disease that are considered in general like low prognostic population, they benefit from the combination. And whether the primary tumor was rectum or colon, you can see that all kind of patients benefit from the combination of zanzalintinib plus atezolizumab, and whether treated with prior anti-VEGF or anti-GFR treatment, or population or BRAF status, which is considered also as one of the poor prognostic factors, all of them, they have benefit and had express overall survival. So with that, the intent to treat population by key subgroups, whether RAS status, as you can see here, or wild type or mutant, you can see that the combination with zanzalintinib and atezolizumab showed better overall survival, 0.79 hazard ratio in the zanzalintinib arm, and for the wild type, and 0.8 for the mutant, which is also in the liver metastatic disease. You can see that also we have the zanzalintinib arm that showed better overall survival in the subgroup population comparing to the regorafenib. It was 89, it was actually 8.9 comparing 7.7. And patients who were treated with the antivascular growth factor treatment antibodies also showed by subgroup analysis better overall survival comparing to the regorafenib arm. So with that, we have the curve that showed the progression-free survival, because this was the secondary endpoint. The PFS actually, median PFS was 3.7 months comparing to 2 months for the regorafenib arm. It was significant if you see that hazard ratio was 0.68. That means 22% risk of reduction of death in population treated with zanzalintinib and atezolizumab combination. And with that, the intent to treat population also, PFS showed positivity with the good hazard ratio, with the best overall response rate. As you can see here, we had a patient that showed complete response, 4 patients comparing to 1 patient in the zanzalintinib arm with atezolizumab, and this is again, I insist, in the proficient population. Partial response was also seen better in the zanzalintinib. Complete response was 0. Sorry, I correct myself, because we are talking about highly. Yes, yeah, I saw your comment from here, Dr. Hassan. So complete response was 0, but partial response was 4 against 1 in the regorafenib arm, and stable disease were 50 comparing to 40. Progressive disease was actually less in the zanzalintinib arm comparing regorafenib, and we don't forget that we do not expect complete response with heavily treated population and who progress after standard line. Objective response rate was also better in the combination arm, and disease control rate showed 54 against 41 patients, and this was actually better in the combination arm. Now, safety overview, when we talk about new treatment, and this is phase 3 trial, of course, we see the safety. You can see that there was serious adverse events, of course, slightly more in the combination, because we are adding multi-tyrosine kinase inhibitor to a simple TKI that is regorafenib. And again, we see the adverse events leading to discontinuation of treatment was slightly more, 18 patients comparing to 15 patients in the regorafenib arm. Serious treatment-related adverse events was also slightly higher in the combination with the zanzatinib with the atezolizumab. Those modifications that were secondary to the adverse events also was more in the combination with the zanzalintinib arm comparing to the regorafenib. In conclusion, the most frequent adverse events leading to discontinuation for the zanzalintinib and atezolizumab was abdominal pain and also asthenia, general physical health deterioration that was seen in 1% of population each, and that considered related treatment by investigation by investigators, and that was intestinal perforation in 2 patients for zanzalintinib patients, and renal failure for atezolizumab altered state of consciousness also was seen, and jejunal perforation was seen for regorafenib. And we know that when we are treating patients with the antivascular growth factor or TKI, we are expecting such adverse events. Here you can see on the top that most important adverse events for the combination was diarrhea for the zanzatinib arm and atezolizumab, while in the regorafenib, the most important adverse events on the 6th line was the stomatitis for the regorafenib. And you can see also that there was more fatigue in the combination. Of course, when we combine multi-tyrosine kinase inhibitor with the checkpoint inhibitor, we might expect somehow more toxicity and adverse events. And you have the also hand-foot syndrome that was more expressed with the regorafenib arm. So with that, subsequent anti-cancer therapy, whether we are talking about the combination with the zanzalintinib and atezolizumab, you can see that population who are treated with combination benefit still for subsequent therapy, that is TAS-102, bevacizumab, and it was somehow equal except for the TAS-102 that was slightly better by 2 patients in the combination arm, and all population, whether the combo or the regorafenib, benefit from subsequent arms therapy. So in conclusion, the study that is called STELLAR-003 is the first phase 3 study which showed combination of immunotherapy and multi-tyrosine kinase treatment, which is in fact first time we are combining for proficient population. It's not deficient and they are not having high MMR. And this is actually in metastatic colorectal cancer. Zanzalintinib with the atezolizumab significantly prolonged the overall survival comparing to single agent regorafenib in patients with previously treated metastatic colorectal cancer. Overall survival benefit was consistent across K subgroup population as we demonstrated in previous study, including liver involvement, which is an aggressive disease. RAS status did not make difference, and geographic region and prior anti-VEGF therapy. Safety for this regimen was consistent with the other immunotherapy and VEGF treatment that we know already about, and TKI combination. No new safety signals were emerged, and most adverse events were less than grade 3, managed with dose modification. The zanzalintinib and atezolizumab represent a potential novel chemotherapy, free chemotherapy treatment prior, that is an option for patients pre-treated heavily with other lines of treatment, including chemotherapy, metastatic colorectal cancer, whether they are BRAF, VEGF, or EGFR, wild or mutant, so all population. This trial continue to plan final overall survival analysis and the subset of patients without liver metastasis. With that, I thank you very much.
Our last speaker, Dr. Kanj, will present his talk the next session. I would like to invite the speaker to have our panel discussion.
I have questions.
So I will, I want to ask just two small questions, and then I will open the floor for discussion. So basically, can we use the circulating DNA as just prognostic, or can we use it as definitive decision and treatment in resectable colon cancer, which means eliminating completely neoadjuvant treatment? This is the first. The second question, in patients who have high MSI, who have complete response, can we avoid surgery?
So in rectal, the second question first, easier. In rectal cancer, yes, we have cumulative data started with Memorial and now with many centers, clearly showing that at 5 years now follow-up, those who have CR, you don't need to do surgery. Even in the proficient, I mean, if we reach a complete response, organ preservation in rectal is done. In colon, it's lagging behind because it's more difficult. See, in rectal, it's easy to do direct visualization, biopsies, MRI, pelvis, besides ctDNA. In colon, it's a little different. If you talk to Ms. Chalabi, she will tell you we are going to reach there too in colon. But I think technically it's a little more difficult in colon. You saw the number 72% CR. So it's tempting in colon as well, but I don't think we are there yet. No, not enough data yet. And due to the anatomy, that it's harder to do colonoscopies frequently because those in rectal, you have to do it every 3 months for the first 3 years. So it's laborious. So I don't think we are there, but we have excellent results. As far as the first question, I think in stage 2, we have better data, I would say, because the risk there is smaller. And if you are ctDNA negative in a stage 2, we always have discussion because anyway, the value of chemo in the stage 2 is not as strong as in stage 3. As Dr. Humaid mentioned at the end of his talk, if you take the T1 to T3 N1, they're actually a good rationale to follow ctDNA and adjust your chemo. But if you take the higher risk, it barely missed, obviously, as he mentioned. So I think it's case by case. I think the concept of prognostic factor, no question, ctDNA negative has a much better prognosis than ctDNA positive. I think the role of escalation is still in question. We have a common patient with Said, but really, I think we are lacking to what to do with these persistently positive or positive negative. They keep going back and forth.
And since we are here and Dr. Said obviously presented very nice data, and it shows that if you are on capecitabine, ctDNA persistently positive, and then we switch you to FOLFIRI, you still have a very high risk of recurrence of disease. Only around 40% of these patients, they turn out to be negative. So the question is that really what to do with this patient who, like the common patient that we have, they become ctDNA positive while or shortly after they have received the previous line of fluoropyrimidine. Should we actually do something more kind of like targeted therapy or move on from fluoropyrimidine and give something else? So this is really, I don't understand.
No, that's right. In this trial, 35 patients were ctDNA positive, and 24 of them then had, after CAPOX, they had 6 months of FOLFIRI. Out of the 24 which had FOLFIRI, 11 became ctDNA negative, but 13 remained ctDNA positive. And out of the 13, 6 then had relapse. So, but they had a good whack of chemo, 3 months of CAPOX, 6 months of FOLFIRI.
Well, it's really treating micrometastatic disease.
Exactly.
I think at that point, these are metastatic disease.
Exactly.
You're just showing that the chemo is delaying further the time of progression.
Yes.
There is something also that we need to tackle is like this ctDNA is not very sensitive for the lung lesions. I think
Peritoneum also.
correct.
Peritoneum and lung.
And myself, I have a patient, and I think some people from here will know about whom I talk. He was followed. He had ctDNA positive, and then negative, and then positive again. And this patient, by scan, showed later on lung metastasis, while the ctDNA was still negative. So this patient, he had finally resection. It was oligometastatic disease, but this also need to be always in mind, you know.
So I just want to add we can also use ctDNA to de-escalate treatment, specifically in the topic that I presented in the metastatic setting. As you know, the plateau of the curves, it shows that we have in the immunological level a good T cell memory repertoire that is durable in the time. It shows that we are eliminating micrometastatic disease. This is why it's like very rare to see a plateau in metastatic colorectal cancer like this for more than 4 years, specifically that the side effect when we do combination therapy, it can be much higher than monotherapy. So we can ask ourselves first question, if we need, I don't think so, but still to reduce less than 4 cycles of induction combination therapy with the nivo-ipi with anti-CTL4. And secondly, if we need to continue nivolumab for 2 years or less, because we have financial toxicity and clinical toxicity.
So in the niche too, they only gave 2 cycles only.
And specifically that we gave lower dose of EP because anti-CTL4 is important in specifically this kind of tumor, metastatic, because they have heavily tumor infiltrated microenvironment, very inflamed microenvironment, heavily neoantigen repertoire, etc. So this is why PD-L1 is not a biomarker that we can use in this setting because it is upgraded or uphanded by the use by MSI and DDMR. So this is what I wanted to add for ctDNA.
One other thing about the ctDNA, especially in Pegasus, is obviously you very narrowly missed that margin of the price. So I think it was 88% 2 years DFS,
Yes.
and they got like 85%. So the issue is that the ctDNA assay actually, which was Guardant, I think, you know, it has only a specificity about 90%. So, you know, how do you actually now, you know, the sensitivity of the Guardant, you just bring this one into account. How do we use it given that the sensitivity is not 100%? So that is also another issue.
Maybe I think there are trials looking into this. How do we de-escalate and escalate? When I was in Nottingham, I was lucky to be the PI of Track C trial, which they are looking into de-escalating and escalating depending on the ctDNA. And we had, I think, 8 patients by the time I left. So I guess it is something which will evolve. It's not ready for prime time, but just needs a bit more good, good data to give us more confidence.
Let me just, I've just been a bit more critical about ctDNA in a minute, but coming back to organ preservation for patients with MSI high colon, do we really need to preserve that part for colon? Because you can get stenosis after response, and then again, you have to do colonoscopy. Why do we need to preserve it? For rectum, it makes sense because it's an organ and you have a sphincter there, but do we really need to preserve colon? That 1 meter of colon. The second ctDNA, I think it's really disappointing to me that's turning into a very expensive tumor marker, just prognostic. But we're not going any further after all of this research. So I think we need to understand this better, that despite having ctDNA positive, we are not able to change the course of the disease. No trial has actually shown this so far, that we can change the course of the disease. We saw yesterday in bladder cancer, again, is prognostic only. So we need to think about how we're going to change the course of disease by using ctDNA. For me, currently, it is just prognostic.
Well, to a certain degree, I agree with you, but I think there will be more trial trying to escalate therapy. I don't think FOLFIRI is the final answer. It's a step because we didn't have anything better. But I think it's our duty now to form more trials to see what we can do about this. But it's a very strong factor, as you mentioned, and patient wants to know, you know, most patient we talk about ctDNA.
The reason that we cannot change the course of the disease is not because your diagnostic tool is a problem. It's just because your rescue system is not good. So, you know, we do not have actually a rescue drug that it can rescue the patient after the ctDNA becomes positive. I don't think that this is a criticism for the test. It is just because of the treatment.
I think it's the clinical implication. So I'll tell you, I have a patient with multiple lung metastasis, and then he had a ctDNA negative in another hospital a month before, and it's just you like, you know, how are we using ctDNA in our practice? We got to be mindful of what the implications are. If you don't have a good radiologist, it doesn't mean that you do a ctDNA to replace a good radiologist. I think I'm just putting this into context. Maybe we are overusing it, over relying on it, and then you have a negative test, but patient has metastatic disease.
An additive test. Again, not everyone shed. You have to have good shedding. You're doing liquid biopsy pretty much. So it is something additive to your PET scan or CT scans.
I think, in my point of view, yeah, the patients now, more or less, they want to know, and we want to know. I know, like, we are missing so many of them when they have peritoneal or lung metastasis. But if you have also patients who develop oligometastatic disease, let's say in the liver, or oligometastatic disease like my patient in the lung, and it's completely resected with margins free, you can also extend this patient and give him opportunity to have like a frame of off therapy, just observation with scans, because you remove the tumor, margins are free. Will you treat this patient?
Well, again, we need data. We need more data about treatment.
So I think we need to end this session, and thank you everyone for this amazing discussion.
Question for Sonia, actually.
Go ahead.
So there have been many previous trial, actually.
I thought you answered that you need more data.
To make proficient MMR sensitive to immunotherapy, the famous regorafenib plus nivolumab, rego-nivo, phase 2 was actually very positive, but then when they did the larger trial, it came out negative. So my question to you is this, do you think it's a good strategy, or is it the zanzalintinib, or could we apply it with maybe regorafenib plus atezo? What do you think?
I mean, the beauty of zanzalintinib, it's a multi-tyrosine kinase inhibitor, and you see.
Regorafenib is.
Yeah, but this one is
call
more
it dirty.
Yeah, but it's more potent, and you see the combination was more potent than I know, like it's almost the same, but apparently the overall survival was positive, so better. I mean, it's still phase 3 trial, so we're gonna see what will happen in future. We don't have yet FDA approval.
Okay.
Look at immunoscores or PDL1 or TSP.
No,
none of these.
no, I
Because
looked,
there's other factors.
I looked at the study. No, it was not in the study. I was expecting this question from you.
Thank you so much, and thank you all the panelists. And I think I need to. Dr. Hassan.
Thank you very much again. So it was a really nice discussion. We have the pleasure of having Dr. 𝗘𝗦𝗀𝗄𝗎 with us now, who is going to talk about the Destiny Colorectal Cancer 02 trial. Thank you so much indeed, Dr. 𝗘𝗦𝗀𝗄𝗎, for joining us.
Thank you, everyone. Thank you for your patience. I know it's a Sunday, sometimes gets hectic unusually. So I'll be talking about the Destiny CRT 02, which is the trastuzumab deruxtecan in patients with HER2 positive patients metastatic colorectal cancer. It's actually a phase 2 trial randomized to look into the dosing between 5.4 milligram per kilogram versus 6.4 per kilogram. So these are patients metastatic who have been treated previously, either treated with anti-HER2 or not. So both patients has been included in this trial. It was divided into two stages. Stage 1, where they looked into the 5.4 milligram per kilogram dose and the 6.4. And then later on the stage 2, they added only the 6.4 milligram per kilogram. And these are patients who are, I would agree, that HER2 positive. The RAS is either wild type mutant, and the BRAF has to be into wild type and resectable. So the endpoint was the confirmed overall response rate. And again, just to reiterate on the point, it's a phase 2 randomized to look into the dosing effect of 5.4 milligrams versus 6.4 milligrams. And if you look into the efficacy, this was the preliminary data. It was in June and in November 2022, and then in December 2024. You see that the preliminary data is still confirmed with the final data that has been presented lately in the ESMO, and that shows that actually the dosing 5.4 milligrams, 6.4 are both plausible. And when you follow these patients for a longer period of time, you see that the 6.4 milligrams has a better overall survival with 19.75 versus 15.9, reminding you this is the phase 2 trial, and this was not the endpoint. The endpoint was, as I said, is the confirmed overall response rate, which you see that at the end of the day that you have 37% response rate with the 5.4 milligram versus only 27 with the 6.4 milligram per kilogram. Now, this is very interesting to look at, and we'll look later on into the detailed findings. Again, with the longer follow-up, we saw that the median overall survival shifted from 15.9 to 19.7 whenever we added the dose from 5.4 to 6.4 milligrams. And this overall survival was consistent at all levels. And then you look into the most important thing about the anti-HER2 therapy that was taken. So it was irrespective if this patient has received anti-HER2 therapy before using deruxtecan or not. This is number one. It was irrespective that about the RAS wild type or it is mutant, which is very important in our clinical practice. And last but not least is about the +2 or +3. So there was more +3, so the +2 in the stage 2 disease and the final was not available. But then again, we see that the overall improvements in survival was at all subgroups and was irrespective of the patient, most importantly, if received previously anti-HER2 therapy or not. Now, if you look at the safety, which is very, very important, we are very excited to add this medication to the colon cancer paradigm. But then again, the more when you added doses, we see that the interstitial lung disease has doubled, not in the grade 5, but you see that the incidence has doubled in the grade 1 as well as the grade 2 incidence of interstitial lung disease, which is something we are more learning every day how to detect and how to treat. So grade 1, grade 2 has been doubled. We don't see much difference into the grade 4 and grade 5, but then again, this is an alarming sign that yes, increasing the dose from 5.4 to 6.4 will increase the interstitial lung disease. But then again, because of our awareness, our close follow-up, probably we're detecting these cases at grade 1, grade 2, and we're able to hold the disease and manage appropriately. Now, as a conclusion, which is very, very clear that these findings support that 5.4 milligram per kilogram is the approved dose for the anti-HER2 for HER2 positive metastatic solid tumor, including colorectal cancer. The safety profile did not change, so we did not see something totally different. And again, this is a single agent use in patients, even if they received previously anti-HER2 therapy or not. Thank you very much for your patience. Thank you. Thank you. Yes, sure.
Okay, thank you so much. We're going to move on to the GYN session now, and it is my great pleasure to introduce dear colleague, Dr. Sachin Trivedi, who is coming from Bombay. He is a director of medical oncology services at HCG Group, ex-Royal Marsden, and also ex-University of Nottingham, and director of oncology at University of Nottingham before. Thank you so much indeed.
Thank you, Dr. Rafi, for the kind introduction. And I'd like to thank the organizers for giving me this opportunity. And I'm really glad to see A lot of familiar faces here. So I've been given about 15 minutes to talk about this very interesting trial. And I think majority of us know somewhat about the data because it's very interesting to see immunotherapy working in ovarian cancer. See, ovarian cancer has been a difficult disease to treat, especially in the recurrent setting. And the ENGOT OV65 keynote B96 trial that was presented by Dr. Colombo in ESMO actually was really well received because, as we know, this is an area of unmet need when it comes especially to the recurrent setting. Let's see if it moves. The green one, okay. So what we're talking about is the platinum-resistant and recurrent ovarian cancer. And I think Dr. Saeed might not remember this, but I was with him, Dr. 𝗘𝗲𝗀𝗳 actually. I was with you in Wolverhampton just before you left. We had the discussion at that point was, what is the definition of platinum resistance? And we used to say 12 months, 6 months. That was the question that supervisor used to ask when we were training. And from there, we realized, oh, platinum resistance is not just 6 months or 3 months or 12 months. It is basically a continuum. And things were evolving at that time. But in spite of so many trials, except for later on, olaparib, this was an area of unmet need. We knew platinum resistance, you give weekly paclitaxel until the Aurelia trial, which showed addition of bevacizumab to paclitaxel did make a meaningful difference to the life of patients. The other thing we know is immunotherapy. So whether to use immunotherapy on its own or combine it with something else, we understand now that, chemotherapy is not going to go out of fashion in spite of all the biological therapies, because chemotherapy does have some synergistic roles, even in use of immunotherapy, because there is data to show that metronomic chemotherapy may boost immune response. And paclitaxel also is known to induce boost immunity by inducing cell death, reshaping the tumor microenvironment, and so on. So the investigators thought for the OV65 trial to combine the paclitaxel and pembrolizumab and see what the outcome of the trial would be. So the eligibility criteria here is histologically confirmed epithelial ovarian cancer. Patients should have had 1 to 2 prior lines of chemotherapy. They should have had radiographic progression within 6 months after the last dose of platinum therapy. Now, even though I said platinum resistance is a continuum, for the trial purpose, they use 6 months as a cutoff to define what is PR or OC. There was some stratification factors that was predetermined. One of them was use of bevacizumab. There was regional variation and also PD-L1 scoring with CPS, 1 versus 1 to 10 and more than 10. The design was, the standard 1:1 randomized trial with pembrolizumab, paclitaxel on one side and placebo with paclitaxel on the other side. The use of bevacizumab was allowed and was left to the principal investigator to decide who would benefit from use of bevacizumab. The primary endpoint here was PFS defined by the RECIST 1.1 by the investigator, but the key secondary endpoint was also OS. Now, remember, this is a very difficult biology of the disease. By the time the patient has reached here, we know that they are in a very, very difficult zone because these are platinum resistant. So after paclitaxel, you don't have anything else to give to them. Having said that, I also think it is a great opportunity to run trials on this patient, because you can produce, if you have positive trials, you can produce results very, very quickly and demonstrate the efficacy. Now here, what they had done is they had given us 2 interim analysis. So one was 1A1, 3rd of April 2024, and the second interim analysis was March of 25, and the data that I'm going to present is after the March of 2025. So let us look at the treatment disposition at 1A2. Important to see this one is because even in next year, we will have some follow-up data from this trial, but almost 90 to 91% of patients had discontinued treatment, which means they had completed their treatment journey. Having said that, out of the 643 patients that were actually enrolled into the trial, about 7.5% of patients remained on treatment at that point versus the 4.7 who remained on treatment on the placebo arm. So there are more patients who on pembrolizumab arm who are remaining on treatment at the IA12. If you look at the baseline characteristics, see, I'd like to highlight a few things here. So they have this predetermined PDL1 thing, bevacizumab use, but see, majority of the patients here had 2 lines of treatment, again defining the difficult patient population, the difficult to treat patient population. In addition to that, if you see the platinum-free interval less than 3 months, even by our very crude platinum-resistant definition that we used to have before, this is the toughest of them all, which is patients who have progressed within 3 months of treatment. So what happens to the PFS? If you look at the PFS in the CPS 1 or more at 1A1, you see a difference of about 1.1 month. The curves are separating. The p-value is 0.014, and at 12 months, the difference is 35.2% versus 22.6%. And this was at 1A2. And this was really encouraging because this, like I said, whatever we saw, even if it was small, it was meaningful and statistically significant. If you look at the intention to treat population at IA1, the difference there was bigger, even in the percentage and the time. See, 8.3 versus 6.4. Again, that was quite interesting to see. Now let us look at the subgroup, and I'd like to, have my understanding of this, and we can share our thoughts later on. Regardless of how the patient population or which subgroup was assigned, based on the forest plot analysis, you can see that majority of the subgroups benefited from addition of pembrolizumab to the weekly paclitaxel, which is very interesting. If you had given them bevacizumab or not given them bevacizumab, did not seem to make a huge difference, and there were good numbers in both the arms. But what is unique here is you look at that patients who had platinum-free interval, if they had less than 3 months of platinum-free interval versus longer platinum-free interval, those who had less than 3 months seemed not to benefit that much in the PFS. Okay, so just mark my word, it is the PFS which is showing that maybe, especially in those patients who had less than 3 months of disease-free treatment-free interval, they may not be doing that very well, even though it is statistically significant. Let us see what it translates into when we look at the future data. So at 1A2, the benefit continued as in 1A1, which is 81.6% of patients were free of any event versus 86.6% in the placebo arm. Similarly, the time gap remained at about 2 months, median months in the PFS. What happened to the OS? This is very useful and very interesting, and I think personally that this will change our practice. Here, what you see, the median survival 18.2 in pembro plus paclitaxel versus 14 months in the placebo arm. Okay, so there is a difference of almost 4.2 months, which I think is even clinically very meaningful. It is not those 2-3 weeks difference that we used to see in some of the trials. So what this is showing, that if you have the right adjunct to a right combination, use a right combination of immunotherapy and chemotherapy, you may be able to bring meaningful and clinically meaningful benefit to the patient, not just statistical difference, but for clinical difference as well. Again, what happened to the OS. Now I showed you the PFS where, let me just go back, yeah. This is my interpretation, and you can correct me. See the platinum-free interval, if it is less than 3 months, the hazard ratio, the forest plot is showing that the treatment difference may not be that much. But when you go to the OS, the same group seem to be benefiting a lot more as compared to the other group. So what it is telling us that immunotherapy may be beneficial for patients who have actually only 3 months of treatment-free interval. They do better than the other peers. Again, look at the objective response rate, a difference of almost 6 to 7% in the treatment arm versus the placebo arm. Again, the ORR in the ITT population, the difference is almost 2.4%. And what happens to the adverse events? Because again, if this disease has progressed because of the anatomical location of the disease, the adverse events and the quality of life matters a lot. And there are no surprises here. If you look at the treatment-related adverse events, they are not very different from what we have seen in other immunotherapy trial. If you look at the conventional toxicities, yes, there is a trend of increasing some of the increase in the peripheral neuropathy, anemia, some degree of fatigue, but I think it is all clinically manageable, and we are well versed in using our clinical skills to manage this. Having said that, immune-related side toxicities, obviously, because there is one arm without immunotherapy and one arm is with immunotherapy, so it's but obvious that we will witness more immune-related toxicities, but none of them were, had caused significant treatment interruption in that arm. So, see, when I was coming, when I was planning to come to Dubai, I was just reading up on a very interesting story about the conquest of Constantinople. 1453, there were a lot of attacks on Constantinople. Again and again, everything failed. But in 1453, there was someone who left a gate open. I think it was a 𝗘𝗲𝗀𝗀 gate or something, and it was a chink in the fortress. Just because of that, the armies were able to enter and conquer. I personally think this is that moment for immunotherapy in ovarian cancer. Because see, this was one of the last fortress that was not captured. Because if you look at all other sites, all epithelial tumors, immunotherapy seems to be doing wonderfully well. 𝗘𝗲𝗀, I think, has a license now, FDA license for 20 sites. But ovarian cancer, because of the biology, because we thought it's a cold disease, it was not, responding to immunotherapy. But now we are showing that actually it is, one, we will have a better understanding of the biology, but the second is also combining the right strategy will help us. So in conclusion, pembro in combination with weekly paclitaxel with or without bevacizumab demonstrated statistically significant and clinically meaningful improvement in the PFS, regardless of PD-L1 status. And like I said, this is the first phase 3 study to report a difference in OS, which is remarkable. And the safety profile is acceptable. And I personally think this is, because we don't have much other option, this is going to, it's already started. I've already started seeing this and offering it to the patients in my practice. Thank you so much. Yeah. Okay.
Thank you very much. Excellent presentation. So we'll move to prostate. We'll have 3 talks. Again, trying to rethink about triplet. So we'll start with Dr. 𝗘𝗦𝗀𝗀𝗀, Consultant Medical Oncology, Chair of Medical Oncology at 𝗘𝗲𝗀 Hospital. So he'll be talking about PSMA addition, new excitement in prostate cancer. Dr. 𝗘𝗦𝗀𝗀𝗀.
So, Assalamu alaikum, still good morning. Thanks, Dr. Said, for the lovely introduction, and thanks for the organizing committee for the invitation and giving me this opportunity. So, good morning, ladies and gentlemen. I'm going to present the PSMA addition trial, which is a phase 3 trial for lutetium PSMA 617 combined with the ADT and the RPI in patients with the PSMA positive metastatic hormone sensitive prostate cancer. So as a background, lutetium PSMA is have been commonly used now in castrate-resistant prostate cancer, and it's working in PSMA targeted radioligand therapy. We have currently 2 indications, one in taxanes naives based on the PSMA-4 trial, as well as in the post-taxane setting in the VISION study. PSMA addition is the first phase 3 study for targeted radioligand therapy in patients with metastatic hormone-sensitive prostate cancer. So this is the design of the trial. So they include patients who are treatment naive or minimally treated metastatic hormone-sensitive prostate cancer. And minimally treated is a new abbreviation. So they mean that those patients receive ADT in neoadjuvant or adjuvant setting, or patients that receive the androgen receptor pathway inhibitor in less than 6 weeks in metastatic setting. So it's 1-to-1 randomization fashion, giving patient lutetium PSMA up to 6 cycles with ADT and ARPI, or the standard of care of ADT and androgen receptor pathway inhibitor. The primary endpoint, radiographic progression-free survival, and for those patients progress, they allowed crossover upon a confirmation from blinded independent committee review, and they looking for a secondary endpoint of overall survival and safety. Stratification factors according to the disease volume as per the charter trial, the high volume or low volume disease, age, and previous treatment with whether surgery or radiation therapy. So the endpoint and analysis, as I mentioned, primary endpoint was the radiographic progression-free survival as per independent review committee. And we have a group of secondary endpoint, including overall survival, response rate, PSA, response rate, quality of life, as well as safety. So patient deposition at the time of data cutoff, they screened almost more than 1,500 patients and 1,420 patients. They had gallium PSMA scan, and they randomized 1,144 a patient with a 572 patient each group. So 99% of the patient treated almost in both group, and almost 19.6% of the patient, they progressed radiologically in the triplet therapy, and 26.6% in the doublet therapy, with the median duration of exposure almost 20 months in each group. And what is interesting, that those patients received 6 doses of lutetium PSMA. It's more than 85% of the patients, and 4 doses or more in almost 93% of patient population. Here, the baseline patient characteristics will balance it between 2 treatment groups, and the median age is 68 year. And if you look for the site of metastasis, so 91% of the patient with bone metastasis, they have quite significant number of patients with visceral metastasis, almost 40%, and 60% of the patient with soft tissue involvement. The allowed patient up to performance status 2, but as you see, it's only 1 patient recruited in the triplet therapy, and tumor volume, almost 68% of the patient with high tumor volume, 50% of those patients with de novo metastatic hormone-sensitive prostate cancer. And here the primary endpoint, the radiographic progression-free survival, was significantly in favor of the triplet therapy, with the hazard ratio of 0.72 translated into 28% reduction in the risk of radiographic progression. And the median radiographic progression-free survival was not met in both treatment groups. And actually, this benefit was consistent across all the subgroup patients, regardless of the age of the patient or the tumor volume, and if they are de novo metastatic or recurrent, whatever the previous treatment being given, the baseline LDH or even PSA. Coming to the interim overall survival, there was a signal toward improvement in overall survival with a hazard ratio of 0.84, but it was immature at time of analysis. Just to highlight it that they allowed in this trial the crossover upon progression from the control arm to the lutetium PSMA therapy. Of other groups of secondary endpoint, response rate was numerically higher in the triplet therapy with 85% versus almost 80%. But what is obvious here, the incidence of our percentage of patients achieve complete radiological response with 57% in the triple therapy compared to 42%. And the time to PSA progression also was significantly in favor of the triplet therapy with hazard ratio of 0.42. The PSA nadir less than 0.2 also was in favor of the triplet therapy compared to the doublet therapy. Time to symptomatic skeletal events was not significant. Time to metastatic castrate-resistant prostate cancer was in favor of triplet therapy with 0.7, and that means 30% reduction in this risk. Progression-free survival also was being significantly in favor of triple therapy with hazard ratio of 0.64. When it comes to the overall incidence of adverse events, we expecting more treatment, more toxicity. However, it seems adding lutetium PSMA to the standard treatment was not associated with severe toxicity. If you're looking for the grade 3 and 4 toxicity, it was reported only in less than 14%. And if you look for the grade 3 and 4 toxicity from the lutetium PSMA by itself, it was around 2%. Treatment-related death, it was 0 in both treatment groups, and discontinuation rate, it was almost in 8% in the triplet therapy. The most common toxicity was dry mouth, nausea, constipation, loss of appetite, vomiting, diarrhea, and dyschezia. And most of these toxicities are grade 1 and grade 2. Grade 3 and above toxicity, it was only single digit in this group of patients. Hematological toxicity as a concern, so they reported the cytopenias. It was reported on almost grade 3 and 4, 14% in patients with the triplet therapy, and it's only 5% in the doublet therapy. Anemia, it's most common in 28%, and neutropenia in 14%, thrombocytopenia in 11%, but again, grade 3 and 4 toxicity, it was only single digit. What about the quality of life? So there was no significant deterioration in the health-related quality of life when it comes to the pain intensity or even the total score. The hazard ratio was 1 in both treatment groups. So the PSMA addition conclusion, combining lutetium PSMA with ADT and androgen receptor pathway inhibitor led to statistically significant improvement in radiographic progression-free survival in patients with PSMA positive metastatic hormone-sensitive prostate cancer versus standard of care. This benefit in radiographic progression-free survival was consistent across subgroup of patients, and there was a positive signal towards overall survival. But we know that many of the patients they cross over upon progression to the control to the lutetium PSMA, which might dilute the overall survival, but we need to wait for longer follow-up. Other secondary endpoint, PSA, BFS, metastatic castration-resistant prostate cancer, and severe side effects was in favor. Symptomatic skeletal events was in favor of the lutetium PSMA therapy, and the safety of the lutetium PSMA with the standard of care was matching with what we know from the PSMA therapy. There was no any new safety signals. And this finding indicated that combining lutetium PSMA therapy with the standard of care provides clinically meaningful benefit for patients with PSMA positive metastatic hormone-sensitive prostate cancer. These acknowledgements, and thank you.
Thank you very much, Dr. Qiman. Let me welcome now Dr. 𝗕𝗲𝗀 Mukherjee, well-known GU expert, consultant medical oncologist at 𝗕𝗲𝗀𝗁 Hospital. So she'll be presenting updated results of the EMBARK study.
Thank you very much. We're saving the best till last, the prostate cancer session as the last session. So it's my great pleasure to present these data, which were discussed by Steve Friedlander at the proffer-papered session, this ESMO. And this is an update which has shown an overall survival advantage in the setting of the high-risk biochemical recurrent prostate cancer. So this really is a huge advance for our patients. This treatment had already been FDA approved based on improvements in metastasis-free survival, but this really underlines how valuable using earlier treatment intensification can be for metastatic prostate cancer, for biochemical recurrent prostate cancer. So these are the backgrounds. This is the EMBARK study, which had significantly improved metastasis-free survival, the combination of either enzalutamide plus ADT or ADT or without ADT, so an enzalutamide monotherapy arm versus ADT alone for patients with high-risk biochemically recurrent prostate cancer. So this is the study design. I think we all remember it well. These are patients who had a rising PSA despite having radical local treatment. So most of the patients had had both surgery and radiotherapy, and they now had a rising PSA with a doubling time of more than 9 months or less than 9 months. And these patients were actually stratified to those patients who had a very rapidly rising PSA versus those patients who had a slightly slower rise in their PSA. And they had no metastatic disease, again, based on conventional imaging. So nowadays we're using a lot of PET PSMA scans. So that's one of the caveats to these data. But the randomization was in 3 arms, the standard arm being ADT alone versus the combination of enzalutamide plus ADT, and there was one enzalutamide monotherapy arm. This treatment was not given indefinitely. This treatment was given for a total of 9 months, and those patients who received treatment and got to a PSA nadir could actually stop the treatment and then monitor their PSA, and then if the PSA rose again, they would then continue on therapy indefinitely. So these are the overall survival results, and this is an 8-year overall survival with a hazard ratio of 0.597. So this is an incredible advance. These are patients who live for a long time. You can see how long these survival curves are going out for. And to have a survival advantage at this stage in patients who have high-risk biochemical recurrent prostate cancer is a major achievement, considering all the other treatments we now have for patients who develop metastatic disease. So these are the pre-specified subgroup analyses. This is, again, just the enzalutamide plus ADT arm versus the ADT alone arm. And all of the patients seem to be benefiting from the combination. We can look at age, we can look at prior hormonal therapy, prior radiation, prior surgery, and all patients are benefiting from the combination. If we look at overall survival in the enzalutamide monotherapy arm, and again, remember this is only for 9 months of enzalutamide monotherapy, and then patients who progressed went back on treatment with the combination plus ADT, there was, this was not significant, but again, there is that separation of the curves with an 8-year survival rate of 73% versus 69.5%. And again, subgroup analysis, we all see it shifting in the right direction, who are benefiting from the addition of enzalutamide monotherapy. Time to next anti-neoplastic treatment with the combination arm, again, a significant improvement. And you can see all these patients living for years without a subsequent treatment. So the question is, are some of these patients perhaps cured with this therapy? 9 months of ADT plus enzalutamide? Does it open the door to potentially using metastasis-directed therapy later on in their course of disease? And so I think this is very significant to our patients, and the level of patients, or the majority of patients, again, not having reached the treatment stage where they need a subsequent anti-neoplastic therapy is incredibly important. And again, this is improved even in the enzalutamide monotherapy arm. Again, 9 months enzalutamide monotherapy, and we're still seeing benefits in a separation of the curve all the way out to more than 100 months. And time to first skeletal-related events, again, this would be expected when we're improving metastasis-free survival for our patients, and this is reflecting both arms equally. progression-free survival on first subsequent therapy. So again, we wonder if we're using these powerful drugs up front, does that mean that they're less effective when we restart subsequent therapy, when we restart the ADT and the ARPI? Are they going to be less effective? And there's no evidence of that from this trial. There's this continued separation of the curves in terms of progression-free survival on first subsequent therapy. So these are the patients who stop after 9 months, their PSA goes up, we restart the treatment. And again, this is the ENZA monotherapy arm. Safety summary, we know the side effects very well of ADT plus enzalutamide. Enzalutamide monotherapy, I just wanted to remind everyone that we do need to consider how to manage painful gynecomastia in patients with enzalutamide monotherapy. So we've been using breast bud radiation therapy, which is an option which we used to do in the old days when we used Casodex, and this works very well. So for our young patients who want to retain their potency, they want enzalutamide monotherapy as an option, please don't forget the breast bud radiation to prevent gynecomastia. So the conclusions of the authors, enzalutamide combination with ADT reduced the risk of death by more than 40% versus ADT alone in patients with high-risk biochemical recurrent prostate cancer. Enzalutamide monotherapy led to a numerically lower risk of death versus ADT alone. Did not reach statistical significance, but particularly with younger patients who want to retain their potency, this is something to discuss with them. Significant improvements into time to first or subsequent anti-neoplastic therapy were seen. Symptomatic skeletal-related events and PFS2, again, underlying how the value of early intensification, even just for a limited time, is having knock-on effects for the patient's treatment journey far into the future, and no new safety signals were observed. This was published in the New England Journal of Medicine, and the authors were thanking the audience. Thank you very much.
Thank you very much. We kept the best for the last. So we've got Dr. Jawahar Ansari, expert in GU cancers. Welcome to Dubai. So he'll be talking about how we are rebranding the chemotherapy because it was so toxic. But he's going to tell us how we can do it better in a triplet. Thank you.
Thank you very much, Dr. Saeed, for that kind introduction and for the privilege to be the last speaker of the day. I'd like to thank the organizing committee for this opportunity. So the key task, as Dr. Saeed kindly explained, is to look at this trial which looked at 3-weekly docetaxel versus 2-weekly docetaxel as part of the combination triplet therapy for metastatic castration-sensitive prostate cancer. As we already know, metastatic castration-sensitive prostate cancer triplet therapy is one of the standards of care in the first-line setting. There is a lot of debate as to which patient group it should be used and the challenges to use the triplet therapy in the frontline setting. The key challenge has been to first identify the patient group where triplet therapy is suitable. In clinical practice, typically we use the triplet therapy of ADT, darolutamide, and docetaxel for patients with rapidly progressive, high-volume disease, young, fit patients, where we feel that aggressive therapy is essential. We all understand the missing gaps in the data that the triplet therapy of ADT, darolutamide, docetaxel has been compared to a doublet therapy of ADT and docetaxel and not to a doublet of an ADT and ARPI. And this will remain a missing gap and will never have the benefit to see whether a triplet of an ADT and ARPI doublet of an ADT and ARPI versus a triplet therapy, is there going to be any difference in the outcomes? So the key challenges are, of course, toxicity, in particularly neutropenic complications, may limit the widespread usage of docetaxel-based chemotherapy. And also, we have seen historically that in mCRPC, there have been phase 2 and phase 3 trials which looked at ADT plus docetaxel at a slightly different dosing of 50 milligram per meter square every 2 weeks in a 4-week schedule. That improved the time to treatment failure and was associated with lesser grade 3 and 4 toxicities, particularly neutropenia, leukopenia, and febrile neutropenia. So the authors hypothesized that triplet therapy with ADT, darolutamide, and docetaxel at a different dose of 50 milligram per meter square every 2 weeks can reduce a grade 3 to 5 adverse events compared to the previous standard of 75 milligram per meter square schedule every 3 weeks, which is what we are used to. So this is the study design of the RSAFE trial. The trial included 250 patients with metastatic hormone-sensitive prostate cancer, good performance status of 0 to 1, candidates for, of course, docetaxel, and stratification high volume, low volume, and key other points here. The standard was ADT plus darolutamide at the standard dose of 600 milligrams twice daily and 6 cycles of docetaxel, 75 milligrams per meter square every 3 weeks, versus the experimental arm of ADT plus darolutamide at the standard dose and 6 cycles of docetaxel given 50 milligrams every 2 weeks on a 4-weekly cycle. Mind you, the key difference, of course, is the overall dosing. In the standard dosing, you had an expected docetaxel dose of 450 milligram per meter square, whereas in the experimental arm, you are giving a higher dose of docetaxel at 600 milligram per meter square overall. And the key primary endpoints were indeed safety, grade 3 to 5 adverse events, and grade 3 to 4 adverse events for neutropenia and death, and key other secondary endpoints, including overall survival. Baseline characteristics were well balanced, a median age around 68, good performance status in the vast majority of patients, Gleason score of 8 and above in over 80% of patients in both arms, predominantly bone metastases, over 80% of patients. Visceral metastasis was seen in only 15% of patients, unfortunately. Typically, we tend to favor triplet therapy predominantly for those with visceral metastases, but here the representation is only around 15%. 83% had high volume disease, 86% in the 2-weekly regimen. The serum PSA was low as well, 12 to 14 in both arms. And you can see the number of docetaxel doses clearly higher in the 50 milligram per meter square. Sometimes you would think that that would attribute to higher degree of toxicity. So the overall dose 1073 in the 50 milligram per meter square, whereas 842 milligrams median and or mean in the docetaxel 75 milligrams per meter square. And the key primary endpoint of grade 3 to 5 adverse events was higher as expected in the docetaxel 75 milligram per meter square at 78.9% versus 61.2% in the docetaxel 50 milligram per meter square. Grade 3 to 4 neutropenia as well higher at 64% in the 3-weekly docetaxel versus 24% in the 2-weekly docetaxel, despite the overall treatment duration being 18 weeks in the 3-weekly schedule and 24 weeks in the 2-weekly schedule. You can see the adverse events. If you look at the grade 3 adverse events, slightly higher for the 2-weekly schedule, but if you look at the grade 4 to 5 adverse events, higher in the 3-weekly schedule. So it's obvious that possibly the grade 3 to 4 adverse events were shifting to a slightly lower grade toxicities in the 2-weekly docetaxel. But if you look at all serious adverse events or all grade 3 to 5 adverse events were similar in both the arms. Premature discontinuation of docetaxel, not that different, 7% in 3-weekly and just under 10% in the 2-weekly docetaxel. So you can say that premature discontinuation was in some ways higher in the 2-weekly docetaxel arm, perhaps because of the longer duration and higher dose of docetaxel given in that arm. But if you look at the grade 3 to 5 neutropenia, clearly higher in the 3-weekly docetaxel at 55.5% versus 20% in the 2-weekly docetaxel. And again, leukopenia was much higher in 3-weekly versus 2-weekly docetaxel. Febrile neutropenia as well, 5.5% and 3-weekly versus 1.7%. The PSA response was slightly better in the 3-weekly docetaxel at 0.16 being the median PSA versus 0.26 and the 2-weekly docetaxel. A percentage of patients achieving a PSA to a level of undetectable level of less than or equal to 0.2, 48.8% in 3-weekly docetaxel, so slightly higher compared to the 2-weekly docetaxel at 41%. So in summary, RSF trial demonstrates a statistically and highly significant clinically meaningful reduction in the incidence of grade 3 to 5 adverse events and a rate of grade 3 to 4 neutropenia or death, regardless of the reason in the experimental approach. There was, despite a higher dose of docetaxel in the 2-weekly arm, you could see that the toxicities were still low. It may be considered a potential new standard of care in that setting, but typically when we're using docetaxel earlier on or the triplet therapy earlier on, you are choosing your fitter patients with poor prognosis disease or aggressive disease, typically with visceral metastases. So if they have, of course, comorbidities, poor performance status, and you're worried about potential toxicity for those patients, maybe that's not the ideal population where you should be using your docetaxel upfront. But if you were considering using docetaxel and have concerns about toxicity, then this is perhaps an alternative regimen to use for those patient population. Further follow-up is needed to determine the efficacy in terms of other oncological outcomes, time to MCRPC, overall survival, time to vein progression, time to skeletal related events. All these will be assessed in further follow-up, including the quality of life. With that, these are the acknowledgements from the authors, and I would like to thank you all very much for listening.
Could I request all my speakers to join the podium, please, including Dr. Sachin as well from the gynae session. So Dr. Imad, Dr. Deborah Mukherjee, Dr. 𝗘𝗲𝗀𝗀𝗀𝗃. We have enough chairs. We have five. We have five. Okay, so we'll probably start with the gynae. So maybe I think Dr. Saeed Rafi already has a question ready.
Yes.
We'll go ahead with that question.
Yeah, very, very nice study, Dr. Sachin. Thank you very much for presenting. But obviously, in that setting, we have mirvetuximab soravtansine as well. And the question now becomes is that, how you're going to actually sequence this treatment. So whether you're going for all your platinum-resistant patients, you're going to go again with taxane plus Keytruda, or you're going to actually go for mirvetuximab in that setting and then leave a little bit more time and then you can give it after that one.
Hello. Yeah. So Rafi, so very important and a pertinent question. And I think the answer is we all have to sit down and think what to do now, because this is a very pleasant problem that from nothing, we've got 3 or 4 options, not only mirvetuximab, but we've also got potentially Enhertu and other ADCs in the making. But if you look at the way you screen the patients who are not eligible for mirvetuximab or ADCs, either biologically or because of the cost, because there is a difference in cost. Pembro has become much cheaper now. Having said that, the depth of response with mirvetuximab is more. So if a patient is eligible, if you can offer, you offer. Now see, in the trial setting, you've got only 2 lines of treatment, but many of our patients, you see, they had 3 or 4, 5 lines of treatment. They may have had mirvetuximab. The actual question would be, what can we offer Pembro after if progression for that? So I think we don't have the answer yet. We'll have to wait for some real world data. I don't know if any of my colleagues have experience with mirvetuximab.
I think the safety profile will be in favor of the pembrolizumab-based therapy, and there is no need for biomarkers. And the point is, those patients previously exposed to taxanes, so if they have neuropathy, so probably we'll avoid paclitaxel for such group of patients, and most of the patients have neuropathy. Folate receptor alpha positive, I think it's almost 30-35%. So this is a group that we have the concern to go for this or that one. But we like the directed therapy. So if positive, probably I will give the priority for mirvetuximab, and then I will use pembrolizumab and chemotherapy later on. For the negative, I will go for the pembro chemotherapy.
Okay, Dr. Jawar, you have a comment for?
Different topic.
Okay.
I have a question for Dr. Imad as well for the PSMA addition. So when you have metastatic castration sensitive patients, sometimes just with ADT and ARPI, the receptors tend to switch off. Like when we do a follow-up PSMA scan in 3 months, you tend to see a complete response. So do we feel that 6 doses is too high to give for the castration sensitive? You think you could have done with lesser doses and achieve similar benefit in terms of response and PSA?
Well, I think in the trial, even those, there is only 85% of the patient receive the 6 doses. But the good thing that about the safety and tolerability, that if you have almost 93% receive 4 or 5 doses, this very convenient for the patient. And if a patient is even in metastatic sensitive disease where the bone marrow is still reserved and patient performances is good, I think the tolerance will be even better. But if I have complete response at 4 doses, I might stop at 4 doses. Why to expose the patient for further toxicity up to 6 doses?
So if we have currently now two triplets available, so if it becomes, we get an approval, so rebranding on the docetaxel 2 weekly, does it make any difference? And if both were available to you in the clinic, how are you going to make a decision about which patients you're going to offer triplet and why?
So I don't think the triplet license will change for the docetaxel. Docetaxel still doesn't have a license in the castration sensitive. It's on all the guidelines. Typically, we've used docetaxel now for over 15, 20 years in the prostate setting, and we know how to dose as well. I'm not a huge fan of the 2 weekly schedule because it has been there even in the castration resistant setting. Perhaps I was the wrong person to present that data, but essentially we've used docetaxel at a reduced dose of 60 milligram per meter square in the 3 weekly schedule, which is well tolerated. For the patients who I feel that is too much as well, I've used weekly docetaxel as the TAX 327 trial. We know that in TAX 327, the weekly did not show survival benefit. So I'm wary of that, but I always switch to the 3 weekly schedule, has been my gold standard at a slightly reduced dose. With the 2 weekly, now we are giving a longer schedule, inconvenient to the patient, and of course with higher risk. So I'll probably go with the 60 milligram 3 weekly rather than as a 2 weekly schedule, which is more intense for these patients for various reasons.
So, Dr. Mukherjee, in terms of choosing between the two triplets, what's your thoughts on how you see that in the future if we have the approval?
Two triplets as in PSMA
Addition
plus,
and the chemo,
yes,
yeah.
again, we really don't know, and it throws up more questions than answers. But as you said, this is a very nice problem to have, like in ovarian cancer and lots of different options. I think we need more risk stratification. So who are the patients who have extremely poor prognostic features that if they don't get docetaxel upfront at hormone-sensitive prostate cancer, they are going to progress so rapidly that they will never get the advantage of chemotherapy. And these may be the AR less driven phenotypes. They may be patients who have RB LARS, P53 mutations. These are all biomarkers which are being looked at, but we don't have anything definitive. And the patients who might benefit from lutetium PSMA upfront may be those patients who have very high volume disease. Again, we can use SPECT imaging to assess them between cycles. We might only need a couple of cycles. We may be able to do better and smarter dosimetry to work out which patients are going to derive the most benefit. But these are never going to be in phase 3 clinical trials.
Yes, Dr. Jawahir.
So just to add to that, I think a better trial would have been those with getting ADT and ARPI, those that don't achieve PSMA complete response, giving them lutetium would have been a much better trial than giving all the patients 6 doses upfront. But having said that, once both the approvals are there, you may have to choose the ones with extensive PSMA avid disease upfront, more for PSMA. Those with visceral metastasis, possibly I'll go with docetaxel. And I think you may have to stratify how you would treat those patients. But ideally, the patient group who is most likely to benefit would have been ADT plus ARPI after 3 months. If your PSMA avid disease is still present, these patients will definitely benefit with the addition of lutetium therapy.
That's one differences between also the two strategies from that clinical trial itself. So the PSMA addition was compared to one of the favorable standard of care was the androgen deprivation therapy and ADT, which is the most commonly used approach. Very rare to use chemotherapy. The other triplet compared to the docetaxel. So it's a matter of addition of ADT and ARPI in comparison with chemotherapy to the chemotherapy. But this is compared to the novel hormonal therapy itself, which is commonly used. So if you have a significant improvement here, so I would be in favor of using the PSMA lutetium therapy with this group of patients. If there is a need for escalation to give a triple therapy for this group of patients, because the trial included almost close to 70% high volume disease.
Okay, Dr. Sachin has a comment.
So, I agree with Dr. Jawahar. I think we all agree that when it comes to metastatic setting, we want to extract the most of each drug so that we can actually sequence and extend the lives of patients. Having said that, there is another principle where we want to offer the best combination upfront to control the disease. But the question that we are discussing about triplet in prostate cancer, I think that triplet is going to be the flavor of the day for a lot of future trials. Even the trial that I presented had a triplet treatment, bevacizumab pembro and chemotherapy. And when we used to design our cytotoxic chemotherapy regime, we used to look at no overlapping toxicity, different mechanism of action. I think those principles are being applied here now for biological therapies. So they're going to be more and more triplet therapy, and it is going to be an interesting next few years to see what the real world data shows.
I have a question for
Dr.
Rahman.
Yes, please. Yeah, I was going to ask him this.
Basically, this trial that you presented shows that HER2 obviously has the activity. You have a PFS of like what 6 to 8 months in the colorectal, in obviously the HER2 overexpressed patient. So first question is that how do you now position this basically treatment? Where do you use it? And the second one is the dosage was different to the dosage that we know already that you're using in breast and other combinations. So how do you explain the dosage? How do you actually manage this?
So this is the Destiny CRC22. So in the phase 1 or the Destiny CRC1, they looked into the dose of 6.4 milligrams per kilogram at that point, and they looked at, they had an overall response rate of 45% using the 6.4 milligram per kilogram, and had about a PFS about 6.9 months. So what they looked into, they can do the same efficacy, but decreasing the side effects by decreasing the dose. And that was the purpose of the CRC2 right now, is that decreasing the dose seemed to be that giving similar efficacy, as you can see on the long term, had good overall survival, but most importantly, the response rate was also good at the 5.4 milligrams. So this is probably a proof that why not we use the 5.4 milligram, the same as in the breast, we use it as well in the CRC. So this is the first thing. The second purpose of the trial is they looked into, in the initial trials, they did not stratify patients according to the RAS and BRAF mutations. In the CRC2, yes, they did. They omitted the BRAF mutations. It was only BRAF wild type, but they included the RAS wild type and mutant. And here they saw the benefit as well in this population, that you can use the trastuzumab deruxtecan in this population. It was wild or mutant, and they had a good efficacy at the end of the day. Now, where you put it is a very tricky point here. How many patients you have of HER2 positive, 2 to 3%, 2 to 5%? Is it +2? Is it +3? So it depends at the end that you cross the second line, you see your patient fit, not fit. It's 3 plus, most likely you're going to introduce it before going to regorafenib or Lonsurf. So I think probably the third line could be the fourth line, or hopefully we can move it forward to the second line if the patient cannot tolerate the regimens as chemotherapy. That would be my point.
Thank you. Dr. Mukherjee, with regards to EMBARK updated outcome, which are really positive, so is going to change your practice, or you've already established this in your practice? And how do you see that moving forward?
Good question. We've already started using this treatment as per the FDA approval based on the metastasis-free survival. But I think having the very clear overall survival data with the combination makes us perhaps push for that more in men who are willing to accept the combination of ADT plus enzalutamide. Although as I mentioned, we do have those category of men who are younger, who want to retain their testosterone, that the single agent enzalutamide is a very good option for 9 months. And we've had very good efficacy. It's quite remarkable how quickly the PSA goes down with just single agent enzalutamide, and the testosterone remains high. And as long as we've sorted out the breast bud radiation, the gynecomastia is not a problem. So this is a very well tolerated treatment.
Thank you. Maybe we'll take a last question in regards to sequencing then prostate cancer. So if we use lutetium upfront, how do we see the role of it in the MCRPC? Anybody?
Still use it again.
I would consider re-challenging later on, of course, depending on the extent of response, the longevity of the patient. Re-challenge lutetium within MCRPC setting is still an option. So of course, if they've used in the castration sensitive setting, I would be in favor of re-challenging these patients in MCRPC, as long as they have PSMA avid disease at that stage. We have only X number of limited treatment options for these patients. So I think re-challenge would be on the top of the agenda for these patients.
Obviously, we'll be in the same situation again, that we do not have a data available for it, but we'll use it. like we've done with all other drugs in the
I
MCRPC?
just wanted to draw everyone's attention. There was one really interesting study presented by 𝗕𝗦𝗁, but it was hidden because it was taken from our mini oral session and put in a separate radioligand session, which was put on at the same time as the plenary session. So this study from Canada randomized patients, it was a phase 2 study, but quite a big one, to either with CRPC, to either docetaxel or lutetium PSMA. So we are really keen to use it sooner rather than later, but actually the patients on docetaxel did better. So lutetium PSMA is a good treatment, but it's not the treatment for every single patient with castration-resistant prostate cancer.
I think it was good that they put it in the other session. There was lots of criticisms for this trial actually, so I think we can discuss another day.
It just gives us some extra insights that the fact that risk stratification, patient selection is really important. There's no one size fits all with prostate cancer.
Good. Anybody has any last questions before we close the session? I think with this we'll complete our session. I think we're going to take awards, yeah? Okay, yes. Can we have? Okay. So Dr. 𝗕𝗲𝗀𝗀𝗁𝗀, please.
Okay, with that, I think, as it is also really we just wanted to thank everybody for attending and also to our sponsors as well. And it is our pleasure that Dr. Falah is with us here and we can thank our sponsors here for this great meeting. Thank you so much. So the first one is our colleagues at AstraZeneca. Next one, our thanks goes to our colleagues at Novartis. Next one, thank you so much indeed to our colleagues at Merck. Thank you so much indeed to our colleagues at Roche. Our appreciation to our colleagues at BMS. Many thanks to our colleagues at Guardant. Grateful to our colleagues at 4Base Care. And with that, thank you so much indeed, everybody. Highly, highly appreciate it. It was really successful meeting, and we are really very grateful for your contribution and participation. Thank you. Thank you.